breast வந்து actually technically it's a modified sweat gland.
Wow, that's a very unique way of looking at it. I have never heard it described as such, even being a doctor and gynecologist myself. Yes, we are going to be talking all about the breast from the best.
Let us welcome Dr. Selvi Radhakrishna. She is the very senior and most eminent and leading consultant oncoplastic surgeons in Chennai.
She completed her DNB in general surgery, went on to do her FRCS
and MSc in clinical oncology from the University of Birmingham, UK.
Further training in breast cancer surgery
at Adyar Cancer Institute and in the UK.
She returned to Chennai in 2007
to set up a state-of-the-art breast cancer center in Chennai called the Chennai Breast Center.
In a short span of 16 years since its inception,
Chennai Breast Center has treated over 4,500 patients.
Cyst வந்து கேன்சர் இல்லை, இருக்கிறவங்களுக்கு யாருக்கு வேணா கேன்சர் வரலாம். சிஸ்ட்ங்கிற போர்வேல you should not miss the cancer. The male breast cancers are rare. It's only like for every 100 breast cancers of women you see, we see one male breast cancer. Illame is lifestyle associated. It's like the body screaming out saying, look, stop doing whatever you're doing, you know. So the pain இருந்துச்சு அதனால கேன்சர் இல்லை, பெயின் இல்லை அதனால கேன்சர் இல்லை, அது ரெண்டுமே
okay.
We should dispel. அதான பண்ண நல்லா இருக்கு சொன்னாங்க, அப்புறம் ஒரு கட்டி இருந்தா கூட they may ignore.
Chemotherapy wise, I mean, it has its side effects, but as you said, it is very horrible sometimes.
Some people don't have any sign of period at all. Some people கீழே விழுந்து பரண்டு they'll have pain. Heart health in Sanola, Savola, bran oil, canola, and these are actually the ones that cause heart problems.
Can we prevent breast cancer?
$1 million.
Yes. If you keep eating cake every day, you may have fewer birthdays. Alcohol intake, does it increase the risk of breast cancer? Yes. Can mammograms cause breast cancer to spread?
This is something has been debated a lot.
So, welcome to another episode of Femiliarise. Let's get the conversation started. Today's episode is something which I'm sure you will not want to miss, and தயவு செய்து சேவ் பண்ணி உங்கள் கன்வீனியன்ஸில் ஃபுல்லாக பாருங்கள், because it is going to be useful for women across all age groups in தான் சொல்வேன். Since we are going to be talking about a part which is very close to our hearts, quite literally and figuratively. Yes, I mean we are going to be talking all about the breast from the best. So பிரெஸ்ட்டை பொறுத்த அளவுக்கு எல்லாருக்குமே இப்போல்லாம் ஒரு பயம் இருக்குது. இந்த ஒரு உறுப்பில் ஏதாவது ஒரு பிரச்சனைனாலும் சீக்கிரம் வந்து டாக்டரை பார்த்துடுறாங்க. பட் இந்த பயத்தை பாசிட்டிவாக யூஸ் பண்ணி நம்ம ப்ரிவென்ஷனுக்கு என்ன பண்ணணும்னு யோசனை பண்ணுறோமா? அது மட்டும் பண்ணுறது இல்லை. எல்லா ஏஜ் குரூப்லேயும் எல்லாருக்கும் பிரெஸ்ட்னாலே breast cancer அப்படிங்கிற ஒரு பயம் தான் இருக்குது. ஈவன் எஸ்டர்டே ஐ ஹேட் டாக்டர் காஞ்சனா, ஆர் கைனகாலஜிஸ்ட். அவளோட 11-year-old டாட்டர் இன்னும் வந்து ஷீ இஸ் நாட் ஈவன் அட்டைன் மெனாரிட்டி. அவள் ஏதோ அடிபட்டுச்சான் ஸ்கூலில், சின்னதாக ஒரு ஹெமட்டோமா இருந்துச்சான், தட் இஸ் ரத்தம் கட்டிகிட்டு இருந்ததான் பிரெஸ்ட்டில். அவங்க அம்மா கிட்ட வந்து கேட்குறாளா, அம்மா எனக்கு ஏதோ இங்கே கலர் சேஞ்ச் இருக்குது, எனக்கு breast கேன்சராக இருக்குமா அப்படின்னு. அண்ட் காஞ்சனா வாஸ் குவைட் ஷாக்ட் அட் திஸ் பிகாஸ் ஷீ டிடன்ட் ஈவன் ரியலைஸ் தட் ஷீ நியூ வாட் திஸ் மென்ட் அப்படின்ட்டுன்னு. ஐ எம் கோயிங் டு இன்வைட் டாக்டர் செல்வி டு எஜுகேட் us all about breast health. Welcome, ma'am, and thank you so much for agreeing to spend your valuable time on this podcast.
Thank you.
So what do you think, ma'am? Do you think that awareness as a whole about breast cancer is too much or has increased nowadays?
It's a bit of both actually. There's one segment of society where there is awareness to the extent that it becomes a paranoia.
Yeah.
And there is another segment which are who are totally oblivious to everything about breast. So it is still there.
Rendu vidama unda.
Do both ways.
Okay. So again, our population is so diverse. I think we come across both ends of the spectrum. And one good thing is, I think a lot of மின்னாடி இருந்ததுக்கு a lot of awareness about okay, breastல ஏதாவது பிரச்சனைனா breast cancer-ஆ இருக்குமோ, போய் டாக்டரை பார்க்கணுமோ அப்படிங்கிற ஒரு இன்ஃபர்மேஷன்
சொசைட்டில இருக்கு.
ஓகே.
இன்னொரு செக்மெண்ட் வந்து நிறைய பேருக்கு இன்னும் வலி இருந்தது அதனால breast cancer நினைக்கல, வலிச்சது வலி இல்ல அதனால விட்டுட்டேன், இது பால் கட்டி எப்பயோ வந்தது அது மாதிரி நினைச்சேன். And then here more than that awareness இருந்தாலும் there is a lot of fear.
Yeah.
Although particularly sort of women in their 50s and 60s, they have a lot of responsibilities never end for a woman.
Yeah.
அப்போ அந்த ஸ்டேஜ்ல டாக்டர் கல்யாணம், பையன் படிக்கிறான், பொண்ணு படிக்கிறா, அப்போ டெலிவரிக்கு டியூ, அமெரிக்கா வேற போகணும் டெலிவரிக்கு. So they tend to postpone பிகாஸ் இதை பார்க்க ஆரம்பிச்சோன்னா அது ட்ரிப் நின்று போயிடும், இல்லை அதாயிடும் இதாயிடும்ட்டு அதனாலையும் டிலே பண்றாங்க.
That is so true, ma'am. And not only commitments, இது do you face in your practice? நம்ம டெஸ்ட்டுக்கு போனோம் டாக்டர் கிட்ட, ஏதாவது பிரச்சனைன்னு சொல்லிட்டாங்கன்னா டாக்டர் அப்படின்னு they want to remain blindfolded. பிரச்சனை போயிடுமா தெரியலனா அப்படின்னு தெரியல, denial.
I can see where they come from because it is so much of issues associated with it. அப்புறம் ஏதாவது போனா அது ஏதோ சொல்லிடுவாங்கங்கிற பயமும் நிறைய பேருக்கு வராம இருக்கிறதுக்கு. அப்புறம் there's a very big segment that gets misled. So they seek attention. எனக்கு வலி இருக்கு இதுன்னு போறாங்க, பட் ப்ரொவைட் சேலஞ்ச் நிறைய இருக்கு. There is no uniform way of assessing these things, and everybody assesses. அதுல வந்து இந்த குவாலிட்டி கண்ட்ரோல், ரிப்போர்ட்டிங் ஸ்டாண்டர்ட்ஸ், அப்புறம் வாட் டு வி டூ, ஃபாலோ த்ரூ ஆக்ஷன்ஸ், இதெல்லாம் வெரி வெரி டைசி. எல்லாம் ஒரே மாதிரி எல்லா இடத்துக்கும் போனால் ஒரே மாதிரி ஸ்டாண்டர்ட் கேர் கிடைச்சோம். ஸோ அதில் நிறைய மிஸ் ஆகுது. அதுவும் there is a big challenge.
Yeah, so I think we are going to be covering each of those things which you have already talked about. So what is standard and what is not standard care என்ன அப்படிங்கிறது நம்ம பேசணுங்கிறது ரொம்ப முக்கியம் தான். So I will start right from the basics. So knowing the basics, what is the breast actually made up of?
Breast வந்து actually technically it's a modified sweat gland.
Wow, that's a very unique way of looking at it. I have never heard it described as such, even being a doctor and gynecologist myself.
Something like that. It is encased between two layers of deep fascia, and developmentally the breast nipple line from the axilla it goes right down to the pubis, and that's why it's quite common to see nipples, rudimentary breast along the nipple line, mammary line. So, and then say the breast actually it starts developing around the puberty. Apart with every menstrual cycle there is a change. It's a very dynamic organ like bones, no? The cells keep changing, and it's very reproductive hormone oriented organ. Like the uterus. So it is made up of, the functional unit of the breast tissue is what we call as this terminal ductal lobular unit, TDLU, terminal ductal lobular unit. So this is the milk factory of the breast. This is ஒரு சின்ன, like if you draw like that, no, like
grapes மாதிரி,
bunch of grapes மாதிரி. அதுலேருந்து இந்த லைக் இந்த கிரேப்ல ஒரு கிரேப்ல இந்த குட்டி குட்டியா ஒரு குச்சி வந்து அது மெயின் ஸ்டெம்ல வர மாதிரி there will be lot of குட்டி ductules, and then there will be கொஞ்சம் major ducts, and the few of these bunch of grapes join together and make a bigger duct, and then bigger duct, and then the major duct which opens into the nipple areola complex. So இந்த கிரேப் மாதிரி இருக்க அந்த அதுல இருந்து acinar tissue-னு சொல்லுவோம், epithelial lining இருக்கும். இதெல்லாம் like less than a millimeter size normally. It produces, this is where the milk or the secretions happen. Milk, we label it as milk when it is produced in the postpartum period. In the breastfeed time. But secretions are there all through. At the time we don't call it milk, it is breast secretion. So normally the secretion is just enough, like sweat madri, just enough. You don't see sweat normally. Sweat, but it doesn't mean that there is no fluid in the skin. There is one layer of like moisturizing fluid in the skin all the time. Above breast sleeve, there will be one constant amount of fluid, not enough for you to perceive outside, but enough for it to be called like it's an active unit. So in the acinar tissue, when stimulated by hormones during it become bigger in size, produces milk which gets conducted through those little kutti tubes mulama. That milk passes out and then gets ejected to the nipple areola complex. But acinar tissue taniya irukka mudiyadhu illaya, it needs a framework for it to see. The framework தான் the fibrous tissue and fat. So the fat gives the volume to the breast and the contour to the breast. அப்புறம் அந்த Cooper's ligaments. These are called suspensory ligaments. The Cooper's ligament, because I told you it is encased in the fascial sheath. Deep fascia splits into superficial layer of deep fascia, deep layer of deep fascia. அது ரெண்டுத்துக்கும் நடுவுல this is encase. And the encase, see, like you have your quadriceps are there, your hamstrings are there in the muscle. It is all attached somewhere to one end of the bone to another end of the bone, and அது மாதிரி muscles எல்லாம் they are attached. So breast is something that has no support. There's no bone inside. So but it's hanging. It's there jutting out. So it needs some support. So on the support தான் the Cooper's ligament. It gets attached to the skin layer, dermal, whatever, the fascial layer. So in the Cooper's ligament, so somebody gains weight and then loses weight. Or pregnancy அப்போ என்ன அர்த்தம்? பேபி வரப்போறது, பேபிக்கு பால் கொடுக்கணும்னா the breast as in tissue multiply in size. Lady gains weight. There is like more fat in the breast tissue, more hormonal activity இருக்கும். அப்போ அந்த she gains weight, breast becomes bigger, couple of sizes bigger. There is a stretch. Then say a lady gains weight and loses weight, yo பண்றவங்க, plus pregnancy, and then you lose weight later. So what happens is Cooper's ligaments get stretched. So on the tautness pyro, and that is why the breast droops over a period of. So basically the support structure nu pathina, the functional unit in the breast is TDLU, and the duct that conducts the milk from the TDLU, like those little pipes. And it brings thing. அப்புறம் இன்னொரு strange thing that we have is the nipple areola complex, the brown part of the nipple areola complex. Just under it, the ducts are surrounded by myoepithelial cells. So it has a special function where the milk it will keep dripping constantly, or it will not come out. So for it to come out, it has to be ejected. So the myoepithelial cells have this contractile function. So if you go and touch the nipple areola, you see the whole thing shrinking, like the touch me not plant money. So that is because of the myoepithelial layer there. And as we get older, the reproductive age, like towards menopause, perimenopause, postmenopause, the myoepithelial layer shrinks, just like everywhere else talarra mari adu. So appa the contractility illadadnala the ducts tend to dilate a little. And dilate a little da ectasia nu sollu. So anga when normally secretions irukum, these secretions are normally absorbed, but when it is dilated, it tends to stagnate there. And when it stagnates there, anything that stagnates, you keep like a bottle of milk or even a cloudy little water, that the sediments settle down to the bottom. And the color of the milk also changes. Technically breast fluid is milk. So that's why in the bluish green discharge you get around menopause or in different situations.
So it's only sediments.
It gets absorbed, but sometimes the secretions, the absorptive faculty koranju poidum. So it sediments there, and then there is discharge because that is a very good culture medium, and nipple is a two-way track. Milk comes out, bacteria can go in also from outside to in. And around the areola, the periductal mastitis, and the mother infections can happen, more so in diabetics. Namurla not so much of a problem, but smokers ku nariya these infections happen.
Increasing problem nowadays, especially in the younger age. So maybe as they grow older, they may have some problems. Yes.
To sum it up, breast enna, it is terminal ductal lobular unit, ducts, small ducts, major ducts. Upon the smooth areola complex with smooth muscle with contractility, then the fibrous and the fat that gives the contour, and then the support system is the Cooper's ligament.
Okay, that's very nice. So that's quite a complex organ, and it's not very simple, though I know it is like one of the most popular part of the female human body அப்படினாலும் there is quite a bit happening there அப்படின்னு சொல்லிட்டு, and you've already taken us very nicely through all the physiological changes which are happening in the breast, not only across ages, but ஒரு மாசமும் நம்மளுக்கு பீரியட்ஸ் வரதுக்கு முன்னாடி வந்துட்டு பெருசா தெரியறது, அதுக்கப்புறம் குறையறது எல்லாமே பிகாஸ் அந்த ரீப்ரொடக்டிவ் ஹார்மோன்ஸ்ல நிறைய ஃப்ளக்சுவேஷன்ஸ் இருக்கும் போது breast tissue-லையும் நம்மளுக்கு அந்த சேஞ்சஸ் ஹேப்பன் அப்படின்னு சொல்லிட்டுனா. ஸோ பிரெஸ்ட்னாலே நிறைய பேருக்கு பிரெஸ்ட் கேன்சர் அப்படிங்கிறது தான் பயம் இருந்தாலும் ஆக்சுவலி நம்ம நிறைய பார்க்குறதுங்கிறது முக்கால்வாசி பிரெஸ்ட் கேன்சராக இருக்க போகிறது இல்லை, அட்லீஸ்ட் இன் அ ஜென்ரல் ப்ராக்டிஸ் லைக் அவர்ஸ், நாட் அ ஸ்பெஷலைஸ் ப்ராக்டிஸ் லைக் யோர்ஸ். and it's going to be a lot of common benign conditions. Benign and நம்ம சொல்லும் போது which are non-cancerous-ஆக இருக்கிற பிரச்சனைகள், அது பற்றி I think we should talk about it so that people will know எது பற்றி நம்ம பயப்படணும், எது பற்றி நம்ம மேபி அந்த அளவுக்கு உடனே கேன்சர் அப்படின்னு சொல்லிட்டு நம்ம டென்ஷன் ஆக தேவையில்லைன்ட்டுன்னு. ஸோ எங்ககிட்ட காமனாக வரதுங்கிறது மாஸ்டால்ஜியா ஆர் பெயின் இன் த பிரெஸ்ட். எல்லாருக்கும் ஒரு வலி வருது. இந்த வலி யூஸ்வலி நம்மளுக்கு பீரியட்ஸ்க்கு வரதுக்கு முன்னாடி வரும், பிகாஸ் என்லார்ஜ் ஆகுது. பீரியட்ஸ் வந்தோடனே கம்மி ஆகிடுதுங்கிறது எல்லாருமே டு அ சர்டன் எக்ஸ்டென்ட் விமன் இந்த ரீப்ரடக்டிவ் ஏஜ் ஃபேஸ் பண்ணுறது. பட் சம்டைம்ஸ் எதுவுமே வலி இல்லாதவங்களுக்கும் புதுசாக வலி வரும்போது அவங்களுக்கு ஒரு பயம் வருது. ஸோ வாட் ஆர் த காமன் காசஸ் ஆஃப் மாஸ்டால்ஜியா? இதுக்கு என்ன பண்ணலாம்?
So we divide it as two things majorly. The cyclical mastalgia, non-cyclical mastalgia. Cyclical mastalgia, it is associated with periods. Cyclic இருந்தாலும் cyclical. இப்போ periods, like I said, in the reproductive age groupல அந்த breast acinar tissue, the size increases and the number of cells increases. So இதுதான் the proliferative phase ன்னு சொல்லுவோம். In the younger reproductive age group, like in the teens, 20s and early 30s every cycle is an anticipation of a possible pregnancy.
Yes.
And the pregnancy does not happen. It comes out as menstruation, and then woman gets ready for the next cycle once again. So adula and the preparatory phase and the progesteronic phase is when all the cells become bigger and more in number.
Yeah.
Adnala breast feels heavier, and there is a little bit of water accumulation also. In the progesteronic phase weight regular check pandravanga will notice that it goes up by another half a kilo or more. You feel a little bloated.
Yes.
And then after the period it all settles down. Adhe mari breast pain, the day the period starts, it settles down. So lot of people actually learn to time their period dates with the breast pain. Definitely. So when the breast pain vandana, okay, my date is due ngra alavukku, it's fairly regular. Yeah. So some people are lucky, they don't have much of it. Some people are unlucky, they have like a lot of people like period pain madra. Some people don't have any sign of period at all. Some people killa vilandu parande, they'll have pain.
Yes.
Adu mari dhaan breast. So adula they may some people right from like 15 days கூட இருக்கும், ஒரு வாரம் தான் வலி இல்லாம இருக்கும், மிச்ச நாள் எல்லாம் வலிக்கிற மாதிரி இருக்கும். And at the peak builds up around premenstrual period. Some people may just notice it for 3 or 4 days. So என்னன்னா the ovulatory cycles are likely to be more painful than anovulatory cycles.
Okay.
And some people like they may not have it during their early reproductive period, but later on it will come. That is when they get scared. தன்னால எந்த பீரியடுக்கும் எனக்கு வரல, இப்போ போய் இது பீரியட் ரிலேட்டட்னு சொல்றீங்களே அப்படிம்பாங்க. It can happen. So முன்னாடி இருந்திருக்கலாம், அப்புறம் இருக்காது, முன்னாடி இல்ல அப்புறம் இருக்கும். So these are all things that change with and like I always connect it to metabolic health, a little bit of obesity, all that also actually triggers
these changes. Okay. And acyclical அப்படிங்கிறது?
So anovulatory cycle, there is not much pain. A period actually people notice it, when there is an anovulatory cycle, they may not have much of that congestion and period related pain symptoms. Similarly breast kum this, so somewhere I think the body recognizes, okay, this is not going to be pregnant, so I don't have to multiply and
really do that my work அப்படின்ட்டு in anticipation of breastfeeding. பட் இப்போது சரி, இது சைக்ளிக்கல் மாஸ்டால்ஜியா பேசணும். ஸோ அது மாதம் வரது தான் டு அ சர்டன் எக்ஸ்டென்ட். பட் நாட் ரிலேட்டட் டு பீரியட்ஸ். எனக்கு எப்போ பாரு பிரெஸ்ட் பெயின் இருந்துகிட்டே இருக்குது அப்படின்னு சொல்லிட்டு சடனாக, அண்ட் நாட் லோக்கலைஸ்ட், ஒரு இடத்துல இருந்தால் நம்ம இன்ஃபெக்ஷன் யோசனை பண்ணலாம். ஓவராலாக எனக்கு 2 சைடுமே வலி ரொம்ப ஜாஸ்தியாக இருக்கிற மாதிரி இருக்குன்னு, அந்த மாதிரியும் இருக்கிறதுக்கு வாய்ப்புகள் உண்டா?
Generally it is again either exercise, sometimes the musculoskeletal pain, neck and radiating down to the arm, madri it can radiate down to the breast. Sometimes you do some pull, all these pec exercises, upper body exercises, yoga, within or muscle fiber in the pec will get pulled, or serratus anterior will get pulled, and it will be a lot of effort pain because breast is sitting on top. And you feel the whole side very heavy and all that. So musculoskeletal generally is unilateral. Very rarely it's bilateral. Generally constant pain, the fibromyalgia type syndrome, like vague pain everywhere else in this issue. And sometimes people also wear the wrong kind of very tight clothes, and they try to fit into 2 sizes smaller, which they bought 10 years ago, and over a period it's so adu mari some issues, and then you change a few things, they feel all right, but generally again it's a reflection of their general health. So then the pro kind of inflammatory and அந்த மாதிரி fibromyalgia, where everywhere it's paining, breast pain arudhu, and this is what they can come and relate to quickly rather than saying anganga valikadhu. In our medical college days, if you remember, we used to distinctly write kai kaal adu mari da iduvum eduthukano.
Okay, so it may not be anything alarming, because generally breast pain nale definitely does not mean that breast cancer appdin sollittu, not all the time, most of the time at least in solla. The next common thing which we see is sometimes if people are doing breast self-examination, kai vechi paatittu ipo aduvum konjam thankfully awareness build up agirudhu, and we'll talk about self-examination in detail a little later. So fibroadenoma அப்படிங்கிறது நம்மளுக்கு சின்னதாக ஒரு கட்டி எனக்கு தெரிஞ்சிருச்சு, கட்டி இருக்குனாலே நம்ம கேன்சர்னு சொல்லிட்டு நினச்சிடுறோம். ஸோ பட் காமனஸ்ட் breast benign tumor is most often going to be a fibroadenoma. ஸோ fibroadenoma நான் எப்படி அவங்க இதை வச்சு நம்ம என்ன பண்ணணும், டெஸ்ட் ஏதாவது எடுத்துக்கணுமா, அண்ட் ட்ரீட்மெண்ட் எப்போ பாரு ஃபைப்ரோடினோமா இருந்தாலே அதை ரிமூவ் பண்ணணுமா, ஏன்னா அது ஒரு இடத்துல இருக்கலாம், மல்டிபிள் இடத்துல இருக்கலாம், ஒட்டையாக போட்டு நம்ம எல்லா இடத்துலையும் எடுத்துகிட்டு இருக்க முடியாது. ஸோ அதை பற்றி கொஞ்சம் சொல்லுங்கள் மேம்.
ஃபைப்ரோடினோமா அகெயின் இஸ் அ பினைன் கண்டிஷன். அதில் இந்த ஒரு breast tissue kind of multiplies and localizes itself, encapsulates itself and produce like polygundu madri lump, and it can vary from a small pebble to a big pebble. Adula the fibroadenomas generally are benign, non-cancerous. So what I say is it occurs in the early reproductive age group, in the teens, 20s, 30s. அப்போ வந்து அந்த ப்ராலிஃபரேட்டிவ் ஃபேஸ் அப்போ தான் நிறையா இருக்கும் இல்லையா அந்த ஏஜ் குரூப்பில், வேர் மோர் செல்ஸ் ஆர் ஃபார்ம்ட் அண்ட் larger, and then with every cycle it changes. So the proliferative stage நிறையா இருக்கிற சமயத்தில் and that எங்கேயாவது தப்பி போய் it kind of multiplies more and encapsulates itself. So in the benign lesions generally they're gentle in nature, they kind of push and grow, it feels like a lump but it's not that hard lump. So இந்த மாதிரிலாம் இருக்கிறது generally it moves like a breast mouse ன்னு சொல்லுவோம் இது clinically. But these days we also depend a lot on radiology. So we do, particularly in younger people, ultrasoundங்கிற டெஸ்ட் பண்ணுவோம். So ultrasoundல there are definite criteria. இந்த feature இருந்தா இப்படி, இந்த feature இருந்தா there is some level of suspicion, இப்படி இருந்தா கட்டாயமா டெஸ்ட் பண்ணோம் அப்படிங்கிறது. Generally as a thumb rule, anybody with over the age of 30 with a new breast lump, I always biopsy. Okay. I don't take it for granted because fibroadenomas are not cancerous. Fibroadenomas do not have a higher risk of becoming a cancer. But fibroadenomas also are breast tissue and they will behave like rest of the breast tissue. அங்கேயும் breast tissue தான் இருக்கு. They will behave like breast tissue. So அங்கேயும் வரலாம். ஸோ அதனால ஃபைப்ரோடினோமா இருந்தது தான் மாறி போச்சுன்னு இல்லை, அது breast tissue மாதிரி தான். whatever risk that the rest of the breast tissue has, it also has. Okay. Any new lump, particularly in anybody over 30, we always biopsy. Okay. The reason being some breast cancers masquerade like benign fibroadenomas. Okay. Like triple negative breast cancers. Okay. This particularly happens in young women. It can happen, and so particularly in the hereditary onset BRCA positive triple negative breast tumors can occur in young people. Okay. I have seen even in the 20s. Okay. So it'll masquerade like a fibroadenoma. So அந்த ஏஜ்ல என்ன பண்ணுவோம் பார்த்தனா ஒரு fibroadenoma தான், don't worry அப்படின்னு நினைச்சிருவோம். அடுத்த 6 monthsல பார்த்தா it will be so large and and these are aggressive tumors also and they metastasize quickly. So அதனாலதான் we have radiological criteria. Yeah. அதுல even if one or two features that are awkward, which do not conform to the normal fibroadenoma description, always have a low threshold to biopsy. Yeah. So after all, biopsy is a small procedure. It's like having a needle prick. அது பண்ணி clear-ஆ மைக்ரோஸ்கோப் அடியில் வச்சு பார்த்துட்டு benign சொல்லிட்டா then I will happy to leave it alone. பண்ணாம நம்ம வந்து you take the risk of not doing anything, there is the odd case that is going to fox you with cancer.
Definitely. And in a country like ours, where நம்மளுக்கு facility to go and meet a doctor, a specialist, get a test done, get a biopsy done, ரொம்பவே வந்துட்டு வெளிநாட்டை பொறுத்த அளவோட நம்மளுக்கு வந்துட்டு it is more easier and it is cheaper also comparatively வெளிநாட்டை பொறுத்த அளவுக்கு. ஸோ when in doubt, as you said, டாக்டரை போய் பார்த்துட்டு ஸ்கேன் எடுத்துட்டு and where needed biopsy suggest பண்றது. And you have said a good rule of thumb is more than 30 unless some other features scanல இருந்துச்சுன்னா and a new lump வருதுன்னா பார்த்துடுறது. I think I remember I came to you about now it must be 7 years ago. I had multiple actually I felt a lump and then I was like, oh my god, நம்மளுக்கு ஃபர்ஸ்ட் எப்படி தோணுது பாருங்க, no I don't have time to get treated or deal with anything right nowங்கிற மாதிரி தான் first thing which come. But somehow I was like, சம்டைம்ஸ் இன்ட்யூட்டிவாக தோணும் இல்லை இது பிரச்சனையாக இருக்கும், இது இருக்காது, முக்கால்வாசி இது இருக்காதுன்னு தான். பட் அகேன் ஐ டென்ட் வாண்ட் டு டிஸ்ரிகார்ட் இட் அண்ட் வி டிட் த ஸ்கேன். அண்ட் ஸ்கேன் பண்ணதில் இந்த மட்டும் கொஞ்சம் ஏசிமெட்ரிக்கலாக இருந்தது, அந்த ரவுண்டாக ஷேப் இல்லை. ஆஸ் யூ செட் இட் வாஸ் லுக்கிங் லைக் அ லிட்டில் பிட் ஒரு 50-50ங்கிற மாதிரி. அண்ட் யூ ஹேட் டன் த பயோப்சி ஆல்சோ அண்ட் இட் கேம் நார்மல் இருக்குன்னொன்னே we will just leave it alone and just follow up and now hardly முன்னாடி இருந்ததோட I would say it's 50% shrunken in size and if it doesn't bother நம்ம வந்துட்டு அதை எடுக்கணும்னு சொல்லிட்டும் அவசியம் கிடையாது அப்படின்ட்டு.
Because they degenerate with time, they become like stones. So then it's basically necrotic tissue which calcifies, so there is no active breast tissue anymore.
Okay.
Those are the very easy ones, you can ignore it.
Just leave it. And sometimes multiple fibroadenomas இருக்கும் இல்லையா, ஸோ எல்லாத்தையும் போய் நம்ம எப்படி எக்ஸிஷன் பண்ணுறது, எக்ஸிஷன் பண்ணி திரும்ப ஃபியூ இயர்ஸில் திரும்ப வந்துருச்சு அப்படின்னு வரவங்க இருக்காங்க. ஸோ அப்படி இருக்கும் போது நாட் எவ்ரி திங் நீட்ஸ் டு பி ரிமூவ்ட், பட் அகென் வேர் இன் டவுட் பயோப்சி பண்ணி நார்மலாக இருக்கான்னு அட்லீஸ்ட் த பிகர் ஒன்ஸ் ஆர் த சஸ்பீஷியஸ் ஒன்ஸ் நம்ம பார்த்துடுறதுங்கிறது பெட்டர்னு இஸ் வாட் வி வாண்ட் டு கிவ் அவுட். நெக்ஸ்ட் காமன் திங் விச் வி சி இன் ஆர் ஓபிடி ப்ராக்டிஸ் அட்லீஸ்ட் இஸ் ஃபைப்ரோசிஸ்டிக் டிசீஸ். ஸோ நான் கை வச்சு பார்ப்பேன், பிரெஸ்ட் செல்ஃப் எக்ஸாமினேஷன் முக்கால்வாசி யாரும் வந்தாங்கன்னா சரி அவங்களே வராங்க ஒரு வாட்டி திஸ் இஸ் அன் ஆப்பர்ச்சுனிட்டின்னு பண்ணுவேன். அது நம்மளுக்கு வந்து ஒரு கட்டி மாதிரின்னு தெரியாது, ஃபைப்ரோஅடினோமானா டிஸ்க்ரீட்டாக ஒரு ஸ்வெல்லிங் தெரியும். பட் அங்கங்கே பார்த்தீங்கன்னா குட்டி குட்டியாக ஒரு சிஸ்டிக் நாடுலாரிட்டின்னு எழுதுவேன். அந்த மாதிரி வந்துட்டு நீர்க்கொத்தாப்பில் ஹோல் டிஷ்யூவே இருக்கும் வந்துட்டுன்னு. ஸோ அகேன் ஸ்கேன் காமிச்சா நிறைய டைம்ஸ் வந்து நம்மளுக்கு குட்டி குட்டியாக சிஸ்ட் இருக்குது, ஃபைப்ரோசிஸ்டிக் டிசீஸ். அண்ட் ஈவன் நவ் தட் இஸ் வாட் ஐ எம் ஹேவிங் அட் கரண்ட்லி, மல்டிபிள் புதுசாக 6 monthsக்கு ஒரு வாட்டி வருது. ஐ ட்ரைட் ஆக்சுவலி கோயிங் அண்ட் வந்து ஸ்கேன் கைடடாகவே ஃபியூ சிஸ்ட்டை வந்துட்டு நம்ம எஃப்என்ஏசி மாதிரி எடுத்து பார்க்கலாம் அப்படின்ட்டுன்னு. ஒன்றும் ஃப்ளூயிட் வரல, எல்லா இடத்துலையும் ஒரு 5-6 வாட்டி குத்தி அதுக்கப்புறம் ஒன்றும் தேவையில்லைன்னு சொல்லிட்டு ஐ எம் ஜஸ்ட் டூயிங் த ஃபாலோ அப்ஸ் ரைட் நவுன்னு. ஸோ வை இஸ் திஸ் ஃபைப்ரோசிஸ்டிக் டிசீஸ்? டு யூ திங்க் இட்ஸ் வெரி காமன் nowadays?
Should not label it a disease. So these are all physiological changes. So like I said, the proliferation happens of the acina tissue. So towards the latter reproductive age group, like say after 35-40, the chances of this woman getting pregnant is less and less likely. Okay. And the body's physiological thing also changes. No, we age, as we age, a lot of changes happen. So the like ovaries, the follicles become lesser and lesser and disappear with age. Adhu madri acina tissue also disappears. And the disappearing and the phase we call it involution. Okay. So with every reproductive cycle, with every menstrual cycle, the early reproductive age group in the teens, 20s, 30s, there will be more proliferation of the acina tissue. Towards the menopause, there will be more involution. So I'm not going to be required. So some of it disappears. And the disappearing component, then kutti ductules go first. Okay. So if you remember that grape with that little stalk, and the stalk actually goes off. Okay. So what happens in the grape balloons? Because the fluid that is produced is not getting conducted or getting absorbed. So it is stretching out like little balloons. So these and the stretching out and forming balloons of microcysts, you will not actually feel it, but it feels heavy for you. Microcysts. And then there'll be some macrocysts which are like 5 millimeter, 10 millimeter cyst. And there is like jumbo cysts, there's big ones. Yeah. There are symptomatic cysts and there are asymptomatic cysts. The asymptomatic cysts are like that flat cyst. They spread over a large area and it's compressible. And because it accommodates a lot of fluid and it spreads across the breast in a large area, you won't feel it as a lump jutting out. And it's also not tender because it's not under like that pressure. Whereas a tension cyst, in a tight space, suddenly there is like a balloon. Imagine you put a lot of water. It's ready to, kunja 1 ml pota it'll burst. So when it becomes like that, you feel like a lump. Suddenly, suddenly it'll be like suddenly it'll be a gush of fluid that is secreted. Next morning, your lemon sized cutty or sometimes even bigger than that. And it also is very painful.
Okay.
And then it feels, and because you feel, you panic that it's a lump, maybe it's cancer. So these are the different types of cysts. And some of these cysts can get infected. Like I said, it's a two-way track. Sometimes bacteria enter through the nipple and closed in and around, some communication will be there and it will get infected. Pericystic collection இருக்கும், the wall thickening இருக்கும், painful-ஆ இருக்கும். அப்புறம் then you aspirate, and most of the time aspiration is enough, no need for any antibiotics. The symptomatic cysts we aspirate.
Okay.
But again, aspirate பண்ணிட்டு we don't send it for cytology because the chance of this being malignant is so remote.
Okay.
And you'll only get debris, some foamy cells, epithelial cells வரும். When do we need histopathology? If there is an intracystic growth.
Okay.
So, papillary cancers are secretory in nature. So, a duct kullara, if there is a papillary growth, the papillary growth, it will secrete a lot of fluid. And the fluid gets walled off and that forms a cyst. And the growth pathikulla or the cyst kulla valandite irukum, cyst secrete aite, cyst perisite. So I've seen papillary cancers that are 10 centimeters, 8 centimeters. But adla and the stalagmites mani keel, the wall keel and the mela pogum ange keel. So tumors can grow like that. Appo a cyst in oda, that is a different issue. But mathematically, if you see all of these things, the cyst they have classical ultrasound appearances. We go by description, clinically தெரியும், அப்புறம் அல்ட்ராசவுண்டும் பார்க்குறோம். Generally fibroadenoma cysticala mammogram is not very contributory. Mammogram வேணும். Mammogram is to rule out a malignancy, but you see shadows, but ultrasound is what we go by to check. But ultrasound is not a standalone test to diagnose. It's always looked in context with mammogram. So a lot of people do only ultrasound and be done with it. And then we miss a lot of mammogram related findings.
Okay, that's very nice. So another fibrocystic disease in solavana. So it's not a disease per se. Sometimes it may be physiologic changes. And ultrasound la நம்மளுக்கு உள்ளுக்குள்ள தண்ணி மட்டும் தான் இருக்கு, வேற எதுவுமே இல்லைன்னா எதுவும் பண்ணோம், பெயின் இருந்தா ஆஸ்பிரேட் பண்ணலான்னு சொல்றீங்க. உள்ளுக்குள்ள ஏதாவது நம்மளுக்கு ஏதாவது டிஷ்யூ சாலிடா தெரியறது இல்ல அப்படி டவுட்ஃபுல்லா இருக்குன்னா அதை மிஸ் பண்ணக்கூடாதுன்னு சொல்லியிருக்கீங்க.
So the symptomatic cysts are one end of the spectrum. So இந்த பக்கம்லாம் இந்த மைக்ரோசிஸ்ட் இதெல்லாம் so இது ஃபுல்லா ஃபைப்ரோசிஸ்டிக் டிசீஸ் லேபிள் பண்ணிட்டு the psychology is பார்த்துட்டு ஒன்றும் இல்லை சொல்லிட்டா they are happy. But you write a fibrocystic disease or you write some diagnosis, then the disease is invested. அப்புறம் 6 months follow up, அப்புறம் எதுனாலும் then paranoia, எனக்கு fibrocystic disease இந்த condition இருக்கு. It's like, then you can never make them feel normal about their breast again. So அதனால I am very careful
not to label unnecessary labels as such.
Symptomatic da cyst இருக்கு. I also tell another thing. Cyst is not cancer. Cyst கேன்சர் இல்ல, சிஸ்ட் கேன்சரா மாறும்னும் கிடையாது. சிஸ்ட் இருக்கிறவங்களுக்கு யாருக்கு வேணா கேன்சர் வரலாம். ஸோ சிஸ்ட்ங்கிற போர்வையில கேன்சர் இப்ப நான் ஒரு தடவை வருவாங்க ஆஸ்பிரேட் பண்ணி விடுவோம், அப்புறம் இன்னொரு தடவை வருவாங்க ஆஸ்பிரேட் பண்ணி விடுவோம், 3வது தடவை வருவாங்க ஆஸ்பிரேட் பண்ணுவோம். இந்த புளி வருது கதை எப்ப பாரு போனா சிஸ்ட்னு ஆஸ்பிரேட் தான் பண்றாங்க. இப்போ ஒரு கண்டி வந்து இதுவும் சிஸ்டா தான் இருக்கும், இதுவா பாத்துக்கலாம் அப்படின்னு விடக்கூடாது. ஏன்னா சிஸ்ட்ங்கிற போர்வையில யூ ஷுட் நாட் மிஸ் த கேன்சர். So that is why any lump you should investigate for its own merits. அது lump நம்மளா அசியூம் பண்ணிக்கூடாது ஃபைப்ரோடினோமா இது சிஸ்ட்னு. ஃபைப்ரோடினோமா கேன்சரா மாறலன்னா கூட, கூடுதல் ரிஸ்க் இல்லைன்னா கூட, ஃபைப்ரோடினோமா இருக்கவங்களுக்கு கேன்சர் வரலாம். ஃபைப்ரோடினோமா டிஷ்யூல இட் பிஹேவ்ஸ் ஜஸ்ட் லைக் நார்மல் பிரெஸ்ட் டிஷ்யூ, அதுல இருந்து கேன்சர் ஆரிஜினேட் பண்ணலாம். அதே மாதிரி சிஸ்ட் கேன்சர் இல்லைன்னா கூட சிஸ்ட் இருக்கவங்களுக்கு கேன்சர் வரலாம்
வேற இடத்துல.
So, அதையே வந்து சிஸ்ட்னு மிஸ்டேக் பண்ணி அது மாதிரி நிறைய பார்க்கலாம். லைக்
எப்போ இதானே அப்படின்னு சொல்ற மாதிரி
அப்படின்னு வருவாங்க. So, these are people who have been coming and then they also miss it.
பிகாஸ் அவங்களுக்கு தான் இதுதான் நம்மளுக்கு தெரியுமே யூஸ்வலா வர சிஸ்ட். அதுவும் வந்துட்டு ஒரு விதத்துல வந்துட்டு டேஞ்சரா தான் முடியும் அப்படின்ட்டு மாதிரி. தட்ஸ் ஃபைன். Another third common thing which we see, not common, maybe uncommon thing which we see is mastitis, unless it is related to pregnancy, breastfeeding timeல அப்படி நம்மளுக்கு பால் சுரக்கிறது, பால் கட்டிச்சு அதுக்கப்புறம் அது இன்ஃபெக்ஷன் ஆகிறதுனா கூட சம்டைம்ஸ் ப்ரெக்னன்சியில் வரும் சில பேருக்கு breast infection which is mastitis. அது தாண்டி கூட சம்டைம்ஸ் வரலான்னு நினைக்கிறேன். ஸோ உங்களோட எக்ஸ்பீரியன்ஸ் என்ன மேம்?
ப்ரெக்னன்சி அசோசியேட்டட், அதாவது டெலிவரிக்கான அப்புறம் லாக்டேஷன் அசோசியேட்டட் இன்ஃபெக்ஷன்ஸ். ஸோ கிராக் நெப்பிள் அண்ட் யூஸ்வலி நிறைய எம்ஆர்எஸ்ஏ இங்கே பார்க்குறோம். ஹாஸ்பிட்டல் அக்வயர்ட் மெத்திசிலின் ரெசிஸ்டன்ட் ஸ்டாஃபிலோகாக்கஸ் aureus. ஸோ இந்த லாக்டேஷன் லாப்சஸ் is one situation where you have to very quickly, because mastitis very quickly it will go on to pharma collection.
Yes.
And quite often the blunt duct, where the not communicating duct, the milk collects, somewhere some bacteria enters and it forms an abscess. இது வந்து அதனால frequent ultrasound பண்ணோம். நேற்று பண்ணோம் மறுபடியும் எதுக்கு அடுத்த நாளேன்னு கிடையாது. Sometimes you see today it looks like a little like inflamed but you don't feel any collection. You do an ultrasound. இன்னைக்கு ஒன்றும் தெரியல அப்படின்னா check again because sometimes the localization can happen. Most of these things are treated by aspiration. We definitely culture them. We specifically ask for MRSA cultures, and if it is then appropriate antibiotics. IND-ங்கிறது இப்போ lactation lapsesக்கு it is very very rare. பண்றதே இல்லை. ஏன்னா IND is so much of disadvantage. போய் general anesthesia could separate the baby and then you make a nick. அப்புறம் அது
பால் வரும் அதுல
discharge. ரொம்ப நாள் ஆகும் அந்த ஹோல் க்ளோஸ் ஆகுது. அப்புறம் there's a risk of it becoming a mammary fistula. அதுல இருந்து மில்க் வந்துட்டே இருக்கும், க்ளோஸே ஆகாது. She has to stop feeding for it to close. அப்புறம் baby will not be encouraged to breastfeed on that treated side. அப்படியே slowly milk dry ஆயிடும். So for all these reasons we do not encourage IND. Most of these are ultrasound guided aspiration. நல்ல local கொடுத்துட்டு wide bore needle, நல்ல ஒரு 18 gauge needle or use a Venflon needle and 3-way இதை போட்டுட்டு you aspirate. Suppose அந்த debris எல்லாம் thick இருந்தா sometimes the needle gets blocked. Flush a little with the other tap and then aspirate. You may have to aspirate 3 or 4 times. It might seem like a nuisance to come 3 or 4 times, but any day better than having an IND for breast abscess. Cost wise, in terms of all logistics and the challenge of dressings, not being able to feed. Yes. Any day I'd go 3-4 times to a doctor to get into aspirator than have an IND. Most lactation lapses are now treated with IND in the aspiration.
I'm sorry, aspiration. Yes.
அப்புறம் அந்த non-lactation lapses are of 2 kinds. ஒன்னு வந்து இந்த பெரிடக்டல் mastitis, like I told you, அந்த duct ectasia, அது சுத்தி nipple areola சுத்தி infection. This occurs mostly in diabetics and the people who take a lot of antidepressants எல்லாம் அந்த நிறைய duct dilatation இருக்கும்.
Okay.
And tricyclic antidepressants particularly. அங்கெல்லாம் வந்து because of the medicine there will be duct dilatation. அங்க நிறைய secretions accumulate ஆயிட்டு they also get a lot of infection. So அது வந்து and mainly வந்து antibiotics and mostly mix of aerobic anaerobic and generally amoxiclavulanic acid combination augmentin and the mari antibiotics we give. Usually it settles out. If it keeps recurring again and again, then a small surgical procedure may be indicated. There's one group of infections called granulomatous infections. These are the challenging ones. And tuberculosis.
Yeah.
More than tuberculosis, unfortunately, எனக்கு இது வரைக்கும் இத்தனை பார்த்ததுல ஒரு 2-3 பேஷண்ட் தான் will document tuberculosis. By the way of MTB or culture. பஸ் எடுத்து கல்ச்சர் கண்ணா 2 months கழிச்சு lab will call you and say this is tuberculosis. Very very rarely we not be able to document tuberculosis. But it does respond to anti-tuberculosis treatment. பட் இப்போ நிறைய லைசன்சிங் இஷ்யூஸ் இருக்குல்ல, நம்ம ஆன்டிடியூபர்குலஸ் பிகாஸ் ஆஃப் ட்ரக் ரெசிஸ்டன்ஸ் வி நாட் அலவுட் டு பிரிஸ்கிரைப் வித்வுட் டாக்குமெண்டட் எவிடன்ஸ் ஃபார் TB infection. So then we stick a name to it, idiopathic granulomatous mastitis. So we do a biopsy, pus aspirate பண்ணுவோம், pus வந்து we send it for culture. And the culture we also ask for these strange organisms. The one name I can pronounce is Corynebacterium. So a lot of other species of all these vague organisms which only the microbiologist will know. Okay. And so these also somewhere it causes some infection there. And then இது MTBக்கும் அனுப்புவோம். Then we do histopathology. So again எல்லாமே ஒரு fear that in the pretext of this we should not miss a malignancy because இது classical infection மாதிரியும் இருக்காது. There'll be like sometimes some malignancies with a little of interstitial edema will look just like this. So miss பண்ணிடக்கூடாதுன்னு அப்புறம் இதுக்குமே வந்து idiopathic granulomatous ப்ரூவ் பண்றதுக்கு biopsy வேணும். So we do a coronary biopsy. So அதில் malignancy இல்லை, idiopathic granulomatous mastitis இந்த Langerhans cells, multinucleated cells இந்த டிஸ்கிரிப்ஷன்லாம் வரும், granuloma seen இது அதுன்னு. ஸோ அதை வச்சுட்டு then we call it idiopathic granulomatous. So idiopathic granulomatous mastitis அதில் வந்து இந்த மாதிரி Corynebacterium அது மாதிரி ஏதாவது வந்ததுன்னா சிம்பிள் ஆன்டிபயோட்டிக்ஸ்னும் அந்த காலத்து ஆன்டிபயோட்டிக்ஸ் கோல்டைமாக்சிசோல், amoxicillin, doxycycline, இதெல்லாம் will work very nicely. And it has to be probably given over a period of time. After it settles down, sometimes it may recur. Many of these are self-limiting, again will not need surgery. If pus forms because it's painful, we aspirate and remove. Most of it's a prolonged thing. People, they get fed up with us, we get fed up with them. It is a difficult challenge. வருது கேட்பாங்க, எனக்கு சொல்லவும் தெரியாது ஏன் வருது. That's why I call it idiopathic, for no reason. Some respond to steroids. We also dabble with a little bit of the Ayurvedic preparation. It's something called guduchi. And some people, if they're refractory to everything else, this seems to work. So it's courtesy some of our friends who've tried it. So this also we try. But this is a challenge. Actually, it's fairly common. In a month, I would see easily 4 to 5 patients. And it's fairly common. Again, these are the patients, if you see, you don't see, most of them will be obese. And, lot of other metabolic issues will be there. Somewhere there is some connection and some inflammation happening. Not like, we've not seen that cause and effect thing, but as a general rule, if you see, most of these people will have
some concomitant problem as such. Okay, so that was a very nice. I mean, I have taken away that nowadays it's better to avoid an IND in a lactational abscess, pregnancy breastfeeding பண்ணும்போது உங்களுக்கு பால் கட்டிக்கிட்டு சப்போஸ் சீல் கோத்துச்சுன்னா அதை ஆஸ்பிரேட் பண்ணுறதே மச் பெட்டர் தென் டைரக்ட்லி கோயிங் ஃபார் அன் IND அப்படின்னு சொல்லிட்டு ஃபர்ஸ்ட் அதை ட்ரை பண்ணி பார்க்கணும் ரேதர் தென் ஜஸ்ட் ஸ்டிக்கிங் டு அன் IND which was like the traditional way of thinking அப்படின்னு சொல்லிட்டுன்னு டெஃபினெட்லி that is a point I have taken அப்படின்னு சொல்வேன். நெக்ஸ்ட் காமன் திங் விச் வி சி இஸ் நிப்பிள்லேருந்தே ஏதாவது டிஸ்சார்ஜ் வந்துச்சுன்னா நீங்கள் அது ஃபஸ்ட்டே சொன்னீங்க கொஞ்சம் அந்த இடத்துல இருக்க தான் செய்யும். ஸோ அதனால் லேஸாக வந்தால் ஸோ இந்த டிஸ்சார்ஜுன்னு வந்தாலே பேஷண்ட்ஸ் பயப்படதான் செய்கிறாங்க. ஸோ டிஸ்சார்ஜுங்கிறது டிஃப்ரெண்ட் டைப்ஸாக இருக்குது. நிப்பிள்லேருந்து வர்றது தட் இஸ் நம்ம பால் கொடுக்கும் போது தட் இஸ் டிஃப்ரெண்ட். பால் கொடுத்து நிறுத்தி 6 மாதத்துக்கு மேலே ஆயிடுச்சு அதுக்கப்புறம் நம்மளுக்கு ஃப்ளூயிட் மாதிரி வரலாம், இல்லை சம்டைம்ஸ் வந்துட்டு பாலாகவே வரலாம், இல்லை நீங்கள் சொன்ன மாதிரி அந்த டார்க் ப்ளூயிஷ் க்ரீன் ஏன் அப்படின்னு நானே வந்துட்டு யோசனை பண்ணுவேன். வித்தியாசமாக இருக்கே இதை நான் ஸ்லைடில் போட்டு அனுப்பணுமான்னு. அண்ட் தட் யூ வெரி கிளியர்லி செட் அது வந்து ஏதாவது டெப்ரியாக இருக்கலாம் நம்மளுக்கு அப்படின்ட்டு, செல்லுலர் டெப்ரி ஆர் பிளட்டாகவே இருக்கலாம். ஸோ இந்த மாதிரி வரும்போது எந்த டிஸ்சார்ஜ்க்கு நம்ம முக்கியத்துவம் கொடுக்கணும், ஃபர்தராக எவாலுவேட் பண்ணணும்.
ஸோ மில்கி டிஸ்சார்ஜ் இஸ் நாட் அ பிரெஸ்ட் ப்ராப்ளம், இட்ஸ் மோர் அ பிரெயின் ப்ரோலாக்டின் ரிலேட்டட் இஷ்யூ. ப்ரோலாக்டின் செக் பண்ணிட்டு ஹேண்ட் இட் ஓவர், ஆர் தைராய்டு சம்டைம்ஸ், hypothyroid also, endocrine people to outturno. So the bilateral multiple duct discharge, so 8-10 holes lirundhu press panna you see multiple holes lirundhu varudhu and both sides varudhuna, it's usually physiologic, konja exacerbated physiology. So somewhere something is like doing a bit more overwork and it's coming out. And on that time, whenever there is milk inside and the fluid inside the duct, like the ducts are little less than 2 millimeters. Adila konja fluid nariya irundha enna agum, imagine 1 drop of fluid. ஸோ அது டர்ஜிடாக இருக்கும்போது breast feels heavy. ஸோ அந்த nipple area feels very tender to touch. And ஸோ அது அந்த milk surgeonங்கிற மாதிரி ஒரு ஃபீலிங் இருக்கும். A drop of fluid comes out, few drops comes out, and she feels a lot better. ஸோ அந்த மாதிரி இருக்கிறது we can reassure saying it's fine and no need to do it. Okay. And the ones that are surgically significant, the ones that we need to investigate to rule out a cancer, something like blood discharge, blood mixed with fluid, and tap water mari fluid, adum like it stains spontaneously. இப்படி குளிக்கும்போது இப்படி பண்ணனா it jets out, like if you see a cow that jets out like a stream, no, like that. If it comes, then obviously some pathology inside. So what can be inside? It can be a papilloma. Papilloma is also a secretory in nature. There will be more fluid. Fluid ulla irundha the turgid agum. Press panna either it spontaneously discharge without even pressing, and so you stain your underclothes or your blouse, or when you press it just juts out. Those are discharges that is significant. Solitary one breast la oru adla multiple ducts la oru duct. So single side solitary duct, serous mixed with blood, and blood itself. So this could be papilloma, it could be malignancies also. So the earliest form of malignancy we say ductal carcinoma and C2, அதெல்லாம் can produce this
kind of picture. ஸோ இந்த டிஸ்சார்ஜ் எல்லாம் இருந்தால் எல்லா டிஸ்சார்ஜ்க்கும் பயப்பட வேண்டாம். தி ஸ்பெசிஃபிக் க்ரைட்டீரியா நீங்கள் சொன்னது மாதிரி இருந்தால் டெஃபினட்டாக வந்துட்டு எவாலுவேட் பண்ணிக்கணுங்கிறது முக்கியம் அப்படின்றது. நெக்ஸ்ட் காமன் திங் ஐ சி த லாஸ்ட் ஒன் பினைன் கண்டிஷன் வரும்போது ஆக்சசரி ஆர் ஆக்சிலரி டெய்ல் ஆஃப் த பிரெஸ்ட். ஸோ இது மெயினாக ஏன்னா எங்ககிட்ட டெலிவரி ஆன பேஷண்ட் சடனாக வந்துட்டு இவ்வளோ நாள் ஒன்றுமே இல்லை, சடனாக ஐ ஹாவ் அ லம்ப் நியர் த ஆக்சிலா, அவ்வளோ பெரிய ஒரு ஸ்வெல்லிங் மாதிரி இருக்குது. அண்ட் சம்டைம்ஸ் அந்த பால் கோத்துட்டா வந்து ஃபுல்லாக வந்து நம்மளுக்கு இருக்கும் போது கொஞ்சம் பெயின்ஃபுல்லாகவும் இருக்குது அப்படின்னு சொல்லிட்டு அந்த அக்கில் கிட்ட ஒரு கட்டி இருக்குன்னு சொல்கிறது. ஸோ ஹவு காமன் டு யூ திங்க் திஸ்
is again fairly common because embryologically, like I said, no, it's a thing extending from axilla to the pubis and the embryonic rest of breast tissue. So it's quite common to have breast tissue, accessory nipple kuda and that இருக்கும் சில பேருக்கு. So breast tissue in the armpit. And அதில் என்னன்னா, and then there's a breast day வந்து it is not limited to this. There is an extension into the axillary, anatomical name கூட இருக்கு. If you go back to our McGregor days, it's called the axillary tail of Spence. Okay. Named after a man called Spence who described it. So this is also breast tissue, yeah. Okay. So this is also going to respond hormonally like the rest of the breast tissue. So when the breast enlarges during pregnancy and during lactation, so lactation appa enna pannom, all these cells become bigger in size, they secrete fluid. Now the rest of the breast milk is going to come out through the nipple areola. Inga, if it is kind of cut off and localized, it will not come out, and it stays there and it gets bigger and it gets bigger. And suddenly, like it's unexplained, திடீர்னு பெருசா வந்துச்சுன்னா they panic. So we examine and it feels normal. Bend out, always scan பண்ணா it'll just show normal glandular tissue. And if anything like big in the pregnancy and lactational breast pathina, the TDLUs what we describe as less than a millimeter will become 4 millimeters. Okay. So அது physiological. And so அது பார்த்துட்டு reassure பண்றதுதான். அது என்ன ஆகும், after feeding is done and when stop feeding she loses weight or the breast becomes slightly smaller, this also shrinks and it becomes loose and the skin tends to fold over itself. Yes. And juts out like one extra hanging breast. And all cosmetically they don't like, and sometimes we just remove it just to because they're not comfortable with the friction. And also on the folds fungus and sweat, and then clothes, sometimes they like to wear sleeveless, and so adnala some people ask, can we do that excision?
So அது காஸ்மெட்டிக் எக்ஸிஷன் வேணும்னா பண்ண வேண்டியதான், பிகாஸ் அகெயின் தெர் இஸ் நாட் மச் விச் இஸ் கோயிங் டு ஹெல்ப் ஷ்ரிங்க் இட், அதர்வைஸ் எதுவும் பண்ணி போக போகிறது கிடையாது. ஸோ நெக்ஸ்ட் ஐ திங்க் வி ஷுட் டெஃபினெட்லி கவர் த வெரி வெரி இம்பார்ட்டண்ட் அண்ட் வாஸ்ட் டாபிக் ஆஃப் breast cancer as it pertains. என்ன இன்ஃபர்மேஷன் people have to know டெஃபினட்டான. This is one cancer which I have had a lot of, even எங்கள் ஃபேமிலியில் both in my side of the family I had 2 family members suffer from breast cancer, and then in Ashok's side of my husband's side of the family we had 3. Orithanga we lost her unfortunately because it was discovered at stage 3. One cousin sister was in her 40s, early 40s when she was diagnosed. So we have seen across the spectrum. My aunt was diagnosed when she was 70. And I remember she came with a very subtle sign and she was so smart to pick it up. She didn't have a lump, she didn't have pain. எதுவுமே பிரச்சனை இல்லை. அவங்க சொன்னது இது மட்டும்தான், பிரியா எனக்கு வந்து நிப்பிள் ஏதோ சடனாக ஒரு சேஞ்ச் தெரியுது, இந்த சைடுக்கும் அந்த சைடுக்கும் லேசாக ஒரு இன்வர்ஷன் மாதிரி. நான் செக் பண்ணி பார்த்ததில் ஐ குட் ஜஸ்ட் see a very minute swelling. நான் உங்ககிட்ட அனுப்பிச்சிருந்தேன் and you had done the biopsy and you even said that எது எப்படி இது பிக்கப் பண்ணி இவ்வளோ ஏர்லியாக வந்து பயாப்சிக்கு அனுப்புறதே ரேர் தான் அப்படின்னு. I was anticipating எதுவும் இருக்காதுன்ட்டுன்னு, but it turned out to be breast cancer and it was discovered at such a early stage. ஸோ அதனால் அதுக்கப்புறம் she went ahead with surgery and she's fine ன்ட்டுன்னு. So a lot of awareness is still needed about this very important cancer, which is the commonest cancer affecting women as far as our country goes. So what do you think is the prevalence in pathona statistics, few statistics, because when I went through a lot of this American Cancer Society site தான் பார்த்தீங்கன்னா இந்தியன் கைட்லைன்ஸ்னு எனக்கு இல்லை 1 in 8 விமென்க்கு வந்து சான்ஸ் இருக்கு அப்படின்னு சொல்லிட்டு போட்டிருந்தது. ஸோ இன் யோர் எக்ஸ்பீரியன்ஸ்
actually not so much here. Something like, a decade back, it was something like 140,000 breast cancers newly diagnosed based on hospital-based registry, not population. And I think it is like close to 170, 180,000 new cancers. Somewhere roughly it kind of translates to something like 1 in 18 women. Unlike the West where it's 1 in 8. But we are slowly heading there. So the challenges are population. Okay. And அங்க வந்து நமக்கு we have a huge population and 1 in 18 is a very 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 big burden for the country to handle in terms of treatment, logistics எல்லாம். So this is significant. So both men and women put together, what cancer tops on this pata? Breast cancer.
Okay.
And obviously in women, breast is the most common cancer. And the risk is, as you get older, the risk is higher. And generally in the West, we say their cancers are much older women, like 50 plus. Inga we see in 40s itself.
Okay.
And so we have to be vigilant.
Okay. So age-wise, which is the commoner range you would say it is?
I would say 50 is still common, but and the 40 to 50. And under 40, the Western statistics is something around 5 to 6%, whereas ours is something close to 10 to 15%. Under 40,
Okay.
40 to 50, ours is as much as 40% of all breast cancers.
Okay.
And 50 and above will be another 50%.
Okay, so that's very, that is definitely something I would take into account from my own practice in Solva, because generally screening starts from 15. We'll talk in detail about screening and you're saying a huge chunk of people then will be missed when they are between 40 to 50. So we'll talk about screening guidelines and I'm sure you can educate us on that. So risk factors for breast cancer அப்படின்னு பார்க்கும்போது we have modifiable ones and non-modifiable ones for any disease. So can you tell us a little bit?
So non-modifiable is genetic. So this is like there are some genes that are mutated and which when it's inherited, most of these are what we call as autosomal dominant. இது வந்து the genes inherit பண்ணா then the risk of getting breast cancer is as high. BRCA1 is as high as 60%. BRCA2 is as high as 40%. And then there are some other genes called PALB2, P10, TP53, CHEK2 mutation. இதெல்லாம் ரொம்ப rare.
So it's a panel of tests which is done usually.
NGS platform பண்ணுவாங்க.
Okay.
So பொதுவா if you see out of 100 breast cancers, only about 5 to 10 are due to inherited breast cancers.
Okay.
Inherited genetic mutation. Amongst the inherited genetic mutation, BRCA1 and 2 still constitutes a large chunk, 80%. And the 20% are the outliers like P10, CHEK, TP53, PALB2, others. So 80% is still BRCA1 and 2.
But இது யாருக்கு டெஸ்ட் பண்ணுவீங்க மேம்?
So this with a strong family history. More than 2-3 people in the family. Immediate family, first degree relative, second degree relative. First degree relatives are sister, mother, daughter. These are like first degree relatives. Second degree, aunt, Perima, Chinnamma, like Perima's daughter, grandmother, இதெல்லாம் become second degree. And so it's maternal, paternal. Amma's side and the upper side doesn't rule out. So you can inherit from the father's side also. So in more than 2-3 people is the combination of breast and ovarian cancer. It could be BRCA2 mutation. Even BRCA1 can have ovarian malignancies. So somebody in male breast cancer in the family, it could be BRCA2 associated. So male breast cancers are rare. It's only like for every 100 breast cancers of women we see one male breast cancer. But it's rare. But if male breast cancer is there, it's usually genetically associated. So on the families, rest of the women also we need to check. And so already diagnosed breast cancer, avungalukku mutation nala vandadana check pandrathu, we select anybody with a triple negative breast cancer, we do genetic studies. Anybody with younger than 40, அவ்வளோ சீக்கிரம் வந்தது ஏன் வந்தது அவங்களுக்கும் we check genetic mutation. அப்புறம் family history and breast cancer indexed, then definitely for them also we do genetic.
So that you'll know whether you have to check the other people in the family also, Ilya.
Then there are some selective drugs that we can choose when we treat, and then we also have to address about in the breast treatment, what about the other breast? I mean, what about the ovary?
Yes.
And the cascade testing, the relatives, our sister, our mother, our children, what do we advise them? So that becomes important.
And now we had even, it was like popularized or brought into the spotlight by a celebrity, the Angelina Jolie effect. So about 10 years ago, she was very public about going ahead with a bilateral prophylactic mastectomy. For a Hollywood star to come out and say that and take that decision is quite big thing, I would say, because cosmetica avanga paakama ponanga, and then you have to talk about oophorectomy or ovaries removal, and then dealing with the aftermath of the ovaries removal and things like that, Ilya. So those are very important discussions, and each person, after knowing the facts, over vati they may choose differently appadina, but it is important them to be aware of it.
We do a pre-test counseling. எல்லாருக்கும் எடுத்தோடனே எழுதி கொடுக்கறது இல்ல. So they should know what they're getting into.
Yes.
And so pre-test counseling, and then we do a pedigree chart, 3 generation pedigree chart, and then they get adukapparam they get sample tested, usually blood sample. Appo results take about a month, sometimes 3 weeks, a month to come. Results பார்த்துட்டு அப்புறம் post test counseling. The test results can be 3 ways. ஒன்னு there is pathogenic mutation அப்படின்னு சொல்லலாம். Then they'll identify where this mutation is, which gene. So then we know this is the culprit, and accordingly we can act. The other is there is no pathogenic mutation. Angiyum clear. So this is not related to genetic mutation. Forget about amongst the known tested mutations, this is not related. So leave them alone. There's one in-between group. There is some variation. It's not quite pathogenic. I can't call it non-pathogenic also. Somewhere in the middle. There's always this middle group. No. The variation of unknown significance. There is some variation, but I don't know whether it is significant or not. So, அந்த மாதிரி group என்ன பண்ணுவோம்? They go into a national kind of a library. So the lab takes a responsibility of following up. So these mutations are repeatedly seen across the world in different situations, in different labs. So they all pool their resources together and keep following up. So a critical mass irukku, நிறைய பேர் across the world are reporting a same mutation in association with breast cancer அப்படின்னா, or the statistical probability, then they declare it as that is also significant. Other the lab takes the onus, and then they should inform the patient and us, the testing for people, and so we don't lose them from the net. And so far இன்னது வரைக்கும் எந்த வியூவர்ஸும் எங்களுக்கு சிக்னிஃபிகன்ட்னு வரல. But this is another interpretation that we have to watch. Variation we should not treat like a pathogenic mutation.
ஸோ ஒரு டெஸ்ட் எடுக்கிறதுக்கு முன்னாடியே அதுக்கு ப்ரீ டெஸ்ட்டாக நீங்கள் என்ன எக்ஸ்பெக்ட் பண்ணணும் டெஸ்ட் அண்ட் தென் போஸ்ட் டெஸ்ட் கவுன்சிலிங் பிகாஸ் ஆஃப் த வைட் ஸ்ப்ரெட் இம்ப்ளிகேஷன்ஸ் ஆஃப் திஸ் பர்டிகுலர் டெஸ்ட் இட் இஸ் வெரி இம்பார்ட்டன்ட்.
It's like sitting on thorns, right? You have 60% or 80% probability of breast cancer, and you're not prepared to deal with that information. So 60% probability சொல்றேன், but so what should I do? How can I reduce my risk? நான் counsel பண்ணா they're not ready for what is to come, they should not do the test.
Yeah.
அப்புறம் நிறைய சோஷியல் இஷ்யூஸ் இருக்கு. ஸோ டெஸ்ட் பண்ணி தெரிஞ்சுட்டா என் பொண்ணு கல்யாணம் ஆகாது, எனக்கு கல்யாணம் ஆகாது, family. So it becomes a stigma. Employment it will become a challenge. So these are not insurance kadikadu, medical insurance kadikadu.
Yes.
So many issues are there. So we have to be very careful, well informed before testing.
Okay.
And then you test pathogenic nu vanda enna pannuvom. There are two options again. One, frequent surveillance. Every 6 months religious examine pannu, tests are due. Mammogram, ultrasound, MRI. Recently one of my friends 6 monthly check பண்ணி கூட for 6 months ultrasound TVS is normal, TVUS is normal, CA125 is normal. 6 months la 6 centimeter tumor, CA125 is 121.
Oh my god.
So see think breast it's a surface organ, you seal every day when you bathe.
Yeah.
But ovary is hidden.
Yes, definitely, and it is detected at a later stage also, unfortunately.
And the ovary is the bigger culprit. Adnala somewhere surveillance on the 6 monthly, adila closer to 40 na, it's better to get rid of ovaries. Even if best I can keep checking, and at the most you can you treat, and most the ovaries become diagnosed bend up. So
definitely.
So surveillance is one option, and then prophylactic surgery, like what Angelina said. So this we call it risk reducing surgery. So we do proactively go and remove the breast, and then some of them go flat. Some of them decide, okay, they'll have reconstruction. So reconstruction is done like with implants. It's done with autologous, where you use your own, belly fat to do microvascular reconstruction. Those are all possibilities. Adhe mari risk reducing bilateral salpingo-oophorectomy. So that also can be done. Other than the 40, the risk is also breast cancer can occur at any age. Younger age also it's common with BRCA associated mutations. Ovarian generally tends to occur slightly later, like 35 and above or 40 and above. So in the 30 adukku keela ovaries ettutona, the quality of life becomes variable. So another you just tend to push it a little, but over 40 we definitely push them into go have it removed. And then these are all triple negative tumors, if at all they have. Okay. They can go on HRT.
Okay.
There's no harm.
Safe.
And and then rest we are going to do surveillance, and if they are risk reducing, then it's even more safer.
Okay.
So somewhere some amount of you protect from disease, but then what is your quality of life? So that's also important.
Definitely. How common do you think these genetic mutations are?
5 to 10%.
5 to 10%. So other, we were talking about risk factors, and we got into the genetics because that was a separate question which we have answered now. So what are the other risk factors, ma'am?
Specifically non-modifiable, I said rest all are modifiable.
Okay.
Rest all are modifiable. Adula reproductive risk factors. Reproductive risk factors, and then it is all centered around estrogen.
Okay.
So the number of menstrual cycles determines see, logic, right?
Yeah.
Every time you have a cycle, the breast tissue is going to change.
Yeah.
Every change can make a wrong change.
Okay.
The wrong change can get propagated.
Okay.
So the simple funda.
Okay.
So the number of menstrual cycles actually dictates. If you look at it, menarche or 14-15 na irukum.
Yes.
And menopause, நிறைய
45 and above.
டக்குன்னு வந்துரும். 40, you ask, they'll have 5-6 children, எல்லாருக்கும் நல்லா breast feed பண்ணிருப்பாங்க, டக்குன்னு ovaries will shut down, fatigue shut down. இப்ப என்ன ஆகுது, menarche happens around 8-9-year-olds.
Yes.
11-year-olds attain puberty, they're all like looking like adult body. அப்புறம் then menopause also is getting longer and longer. நிறைய பேர் even past 50 they're menstruating.
Yes.
And goes on till 53-54.
Yes.
Also அதுக்கப்புறம் நிறைய HRT வேற, because they're not able to cope up with menopausal symptoms, and some amount of hormones are also given. So but there's a lot of awareness.
Children are less. ஸோ அதனால் நம்மளுக்கு அந்த அமெனோரியா இருக்கிறதே இல்லை, பீரியட் சைக்கிள்ஸ் இருந்துகிட்டே இருக்கு.
And the age at first childbirth, so something has to happen within that time frame for the body to recognize, make certain decisions. And the longer you leave for your first childbirth, that's also seen as a slightly higher risk.
Okay.
And then breastfeed panna, women don't get their periods for the first 4 or 5 months. அதுவும் ஒரு protection. இப்போ நிறைய பேர்னால breast feed பண்ண முடியறதில்ல. And இந்த partially feedனா கூட என்ன அர்த்தம், டக்குன்னு periods come back. So all these...
That protection effect is lost then.
So this accounts for about 25%. All these are again lifestyle associated.
Yes.
If you look at it, why do people start menarche earlier? It's because of childhood obesity.
Yes.
Why people menstruate till very late in life? Again, very adult obesity. So if you technically look at it, and the reproductive risk factors also comes within the lifestyle associated disease. And to me, I've done a lot of to see honestly, I've been doing this for 2 decades now.
Yes.
And, at a point, you're only treating the disease. Where is the root cause? Why are we treating only the disease? Why are we not addressing, preventing this? And what can we do to, in giving all these toxic treatments to reduce the risk of relapse? Can we not address it by the root cause to, even if you don't prevent it altogether, prevent a relapse?
Yes.
Rehab them better so they reduce the risk of recurrence. And so this was the trigger factor for me to go into lifestyle.
Okay.
And now I can see the association, particularly post-menopausal ER/PR positive breast cancers almost always are associated with visceral obesity.
Okay.
And they are lifestyle associated. And so they either are overtly obese, their BMI is also high, and the body fat percentage is high, and they have this, what we call as VAT, visceral adipose tissue. Okay. That is also high. And there is one group of people who are thin, but toffee. Thin on the outside, fat inside. So you do a DEXA scan for them, they'll be slim, they'll be diabetics. And then you do a DEXA on them, VAT will be over the roof, will be 1,000 centimeters square. Normally it should be 100. Fat in the wrong place.
Yes.
Inflammatory chemicals. And these produce insulin resistance, IGF pathways, mTOR pathways. All this are centered around obesity.
Okay.
And insulin resistance. So fundamentally it's all boils down to what we eat and
what we do and lifestyle, how we live our life. So even for something as important, so ஒரு sugar, BP, cholesterolங்கிற பிரச்சனை இல்லை, something as important as breast cancerக்கு what you can do to prevent yourself from getting it in, it all boils down to again lifestyle, your metabolic healthங்கிறது is a very important message.
End of the scene, lifestyle associated disease from neurodegenerative disorders, from dementia, depression, Alzheimer's Parkinson's to all your fertility, PCOS, cancers, particularly breast, some colonic cancers, again fiberless diet, then your cardiovascular disease, stroke, or arthritis, all the inflammatory conditions, ellame is lifestyle associated. It's like the body screaming out saying, look, stop doing whatever you're doing.
Yes, and then it's punishing us. If we punish our body, it's punishing us in some manner. So it's like reciprocal and solid. So that's a very important message. Thank you, ma'am. So is there a condition where இப்போ ஒரு கேன்சர் நம்மளுக்கு breastல கேன்சர் வந்திருக்கு, are we more prone to develop it? நீங்கள் இப்போ இந்த ஜெனட்டிக் காம்பனன்ட் இல்லாம நம்மளுக்கு இன்னொரு breastல வரதுக்கான வாய்ப்புகள் கூடுதலா?
Environment, no. Whatever happened in one breast can happen in the other breast too. Okay. So the risk is something like 6 to 7%, which is why we don't keep bringing them every year for a mammogram. So in the US they go crazy. They go on எல்லாத்துக்கும் double mastectomy. முன்னாடி டபுள் மாஸ்டெக்டமி பண்ணிடுவாங்க. இன்சூரன்ஸ் இஸ் கோடட் டிஃபரெண்ட்லி, கெட் பேட் மோர்னு பண்றாங்களோ என்னமோ. the women are paranoid. So I would say if you have an index breast cancer, say on the right side, the chances of the right side breast cancer spreading to visceral organs like liver or lung or even brain and thereby causing a risk to life is much higher than a new breast cancer occurring on the other side.
Okay.
So in the double mastectomy should be reserved for known or proven mutations.
Okay.
And I am a little reluctant to do a double mastectomy otherwise.
Okay.
But some people ask and we have obliged sometimes.
Okay.
So the risk is something like 5 to 7% over follow-up.
Okay, and they are going to be under follow-up anyway, Ilya. Okay. So what are the symptoms of breast cancer, ma'am? Which the patient comes to you with.
We would ideally like to see them without any symptoms, something picked up early. But if at all, any lump, we should evaluate. We should not take it as pal katti, neer katti, fibroadenoma and dismiss pannu. Any lump should be investigated. Pain or painless, we should investigate. So the pain and painless is a very relative thing. சில பேருக்கு இருக்கிறதே தெரியாது, சில பேருக்கு கொஞ்சம் ஏதாவது இருந்தாலும் ஒரு எவினஸ் தெரியும். ஸோ பெயின் இருந்துச்சு அதனால கேன்சர் இல்லை, பெயின் இல்லை அதனால கேன்சர் இல்லை, அது ரெண்டுமே we should dispel. எதா இருந்தாலும் பார்க்கணும். ரெண்டாவது, see when you look at yourself, you see a contour change or a skin change, definitely you should get checked up.
Okay.
That will include skin tethering, nipple putting inwards, and the contour அதெல்லாமே வந்துடும். அப்புறம் இனி நான் சொன்ன மாதிரி discharge, something that is happening on one side, one duct, serous, that means tap water மாதிரி இருக்கும், and serosanguinous, like serous little bit mixed with but now or color like it bloodish dilute பண்ண ஒரு color, then blood itself. So இந்த மாதிரி discharge வந்தா definitely it should be investigated. அப்புறம் any lump in the armpits also don't ignore. நான் சொல்லுவேன்.
ஓகே. அண்ட் சைன்ஸ்னு நம்ம டாக்டர் கிட்ட வரும்போது நீங்கள் பார்க்குறீங்க இது சஸ்பீஷியஸ் ஃபார் கேன்சர்னு நீங்கள் பார்த்து சொல்கிறதுக்குன்னு ஏதாவது சில சைன்ஸ் இருக்கா?
லம்ப் த way it feels in the skin thickening, like orange தொல்லி மாதிரி சொல்லுவோம், toddy orange ஒரு
மாதிரி
pitted appearance. That is usually because of lymphedema in the skin, localized edema in the skin. Nipple areola ulla vaangi irukathu, and then the retraction, not all retractions are cancerous. You get physiological retraction also. So there's a differentiation that we will know when we see it. Apro axillary lymph nodes irka paapom. Apro evlo to the extent when we see size evlavu, what is the extent, what quadrantal, various ways
மூவ் ஆகிறதா இல்லையா இதெல்லாம் வச்சு நீங்கள் டிசைட் பண்ணுறீங்க. அண்ட் ரொம்ப ரொம்ப சம்டைம்ஸ் இந்த கோவிட் டைமில் ஐ திங்க் இட் வாஸ் லைக் வெரி சேட் தட் a lot of women were also sitting at home without, they didn't want to step out, go to the doctor. ஒரு ஃப்ரெண்டு வந்து அவங்க மதர் இன் லாக்கு வந்து இப்படி ஒரு ஃபோட்டோ தான் அமிச்சாங்க. எப்படின்னு பார்த்தீங்கன்னா அவங்க இது கொஞ்சம் நாளாகவே இருக்குன்னு, ஆப்வியஸ்லி ரொம்ப நாளாகவே இருக்குன்னு சொல்கிறாங்க. டாக்டர்கிட்ட போய் அவங்க பார்க்கவே இல்லைன்னு, அது பார்த்தாலே தெரியறது அவ்வளோ ஒரு அல்சரேஷன், எவர்டட் அல்சர் ஆன் த ஸ்கின், ரொம்ப ரொம்ப முத்தி போய் விட்ட ஸ்டேஜுக்குன்னு நம்ம அதை சொல்வோம் இல்லையா. இட்ஸ் வெரி ரேர் டு see ஆல் தட். அந்த மாதிரி இருந்திருக்கா. அவங்க வீட்லேயே உட்காந்துருக்காங்க, டாக்டர்கிட்ட போயிட்டு கோவிட் டைம்னு சொல்லிட்டு, and then when she was diagnosed it was like very advanced இல்லையா.
So actually we saw that, I maintain very good stats for my practice. And the COVID time, there was a dip. Normally I operate around 300 breast cancers and in a year.
Okay.
So on the particular year, 2020 and 21, the dip was very significant. It was like, came down to 180, 117. But the following year, 22, nanikkana, boom actually. And all of them were, like you see, mine is a slightly more urban practice, more affluent, educated women practice. So, compared to regional cancer institutes and government institutes, my practice, the women come with slightly earlier cancer.
Yes.
So stage 1 and 2 will be 60 to 70% of my practice, and the stage 3 where we operate will be about 30-40% after. So whereas regional cancer institutes, government institutes are reverse look. They'll see more advanced cancers. It was less aware people, less affluent and but on the particular year there was a dip, and the subsequent year 22ல எல்லாமே locally advanced. நிறைய அப்படியே the ratio reversed. All we were seeing was
advanced
stage 3 disease நிறைய. So the reluctance to get out of home because of COVID was a main deterrent.
Even though doctor நம்மலாம் வந்துட்டு I think we were all working and everything was going on, நாலும் I think a lot of people and the scareliye வந்து put it off.
And the first phase of COVID, even we were unsure. And the second phase, we were all told to restrict our elective surgeries.
Yes.
So because oxygen availability. So there's a lot of challenges. நமக்கு staff கிடைக்கல நமக்கு, and so many of them were not able to come, lockdown. So various issues and everybody falling sick. So
Yeah.
So then I was sick, and then isolation, overall isolation, everybody was so a lot of
challenges, and it was sad. And in the madriyum it resulted, and as you have said, on the advanced stage disease becoming more common, unfortunately. So what are the screening methods? You said that preferably அது கண்டுபிடிக்கிறதுக்கு முன்னாடியே லம்ப் அவங்க வரணும்னு சொல்லிட்டுன்னு. ஸோ ஸ்க்ரீனிங்கன்னு சொல்லிட்டு breast cancer preventionக்கு என்ன வந்து is the guidelines? What do they say?
Actually, it will be more like early detection, because you are looking for to detect. Prevention is you don't want it at all.
Yes.
So that will be a separate topic altogether. The early detection, the mammography is the most validated test.
Okay.
Alana, the whole world is divided over mammography. Controversy never ends.
Okay.
Should we screen or should no mammography screening debate in Google millions of pages.
Okay.
So there is mixed divided opinion about screening.
Okay.
So the American Society of Oncology, upon the Imaging Society recommend screening from age 40. And so the United Preventative Task Force suddenly came up with the decision, screen only after 50. Between their own associations, Surgical Association, Breast Association, Imaging Association, will have different guidelines. So anga or confusion anga. Europe, they all start around 50, because their majority of their cancers are postmenopausal, and they tend to occur after the age of 50. So their screening protocol starts from age 50. Majority of them screen between every 2 years. UK does it every 3 years, up to age 70. After age 70, they make it voluntary. If you want, you come proactively, we'll screen, but we will not invade you. It's state funded, it's free, it's a government initiative.
Okay.
Whereas US, it's not state funded, it's like insurance funds it, or they have to go and pay for it and get it done. It's their own, like whatever. On the US, it is not free mammograms.
Okay.
Whereas European countries, more like socialist countries, government funded, and frequencies like that. Switzerland actually took a call about 10 years back. The Switzerland policy will be based on referendum.
Okay.
They'll put through a referendum where people vote to decide this way or that way.
Okay.
So they said, okay, mammographic screening debate, should we offer it as a national screening thing, or it should be... So a lot of people don't like to have mammograms, and they kind of, when they get an invite, they're kind of feeling forced to go and have a mammogram. So they put it to vote, and Swedish women opted not to have regular screening mammogram. So Sweden does not offer national screening program free of cost to any Swedish women.
Okay.
But there is opportunistic screening available. Like our country, we don't have an organized screening program, but what we have is opportunistic screening. If somebody I don't have any symptom, but I walk into my clinic and they over 20, I'm going to do that.
Yeah.
But I'm not going to go and advocate screening. Ellarim boy population pura paniko. Because there are several challenges.
Okay.
So on the Switzerland, opportunistic screening, high-risk screening exists. High-risk screening யாருக்கு இந்த மாதிரி family history, genetic mutation, known mutation, suspect mutation, இதெல்லாம் high-risk category. அங்கெல்லாம் definitely பண்ணணும். And the opportunistic is, I am conscious of my health, I want to proactively check, no harm, get it checked. So இதெல்லாம் இருக்கு, but as a policy it's not given. But it will be interesting to see their incidence, prevalence and mortality rates, and then in Switzerland. Then there will be a lot more answers. So it will take a bit longer for us to have some info on it.
But நம்மளோட population பொறுத்த அளவுக்கு நீங்க advise பண்ணணும்னு நினைச்சீங்கன்னா, though it's not a guideline or a international body, then
still recommend breast self-examination.
Okay.
So knowing what is normal for you and not how your breast looks like and feels like is more important. And அது consistent from puberty, if we educate, like எப்படி menstrual hygiene சொல்லி தரமோ அது மாதிரி இதையும், because it's a dynamic organ, keeps changing. Just a podcast like this, if they listen to it, they get all the information.
Yes.
So regularly check பண்ணிக்கிறது is still a very valuable thing,
even from their 20s.
Yes, just as a like menstrual hygiene மாதிரி.
Okay.
And it's not that so anything they go and checked up, and ஒரு healthy awareness. It should not be a paranoia. Don't talk about disease screening to them. Talk about this is not
knowing your body.
It's like you brush your teeth, you அது மாதிரி இது once a month பண்ணிக்கோ அப்படிங்கறது ஒரு educative thing without this sense of disease
or fear
attached to it. So this is something which everybody can do.
Okay.
அப்புறம் clinical breast exam for the masses, if you say. No, I'm not, again, very clear. It's not for individual decision is different, but for a masses, if you say clinical breast examination by trained staff, it could be a VHN, like, if you're looking at a rural village somewhere down Chengalpet or Viluppuram, அங்க அவங்கள போய் mammogram சொல்லி பண்ணிட்டு அப்புறம் what happens after அதெல்லாம் difficult. So அங்க clinical breast examining, it's like a sieve, so you have the jallada, if you see jallada holes பெருசா இருக்கும், then சின்னதா இருக்கும், so you see according to the section of society and the population concerned. இந்த routine இந்த screening advocate பண்ணி இந்த மாஸ்டர் செக்அப் பண்ணி போட்டு இந்த பஸ்ல மேமோகிராம் போட்டு இந்த ரோட்டரி அது இதெல்லாம் ஸ்பான்சர் பண்ணி it is good in a way that causes an awareness about breast cancer, but it is also has some negative connotations. In the end எதா பண்ணிட்டு so for it you have to screen in the general population. I'm not talking about high risk, I'm not talking about patients with symptom. Screening is done for people with no symptoms. So anga poi if you do screening to pick up, you have to screen 1,000 women to pick up 5 to 6 breast cancers. So 1,000 women poi mammogram பண்ணீங்கன்னா ஒரு 5-6 பேருக்கு mammogram breast cancer இருக்கு கண்டுபிடிக்கலாம். அது என்ன பார்கெயின் என்ன, அங்க ஒரு 200 பேருக்கு will call out something else as suspicious and over investigate. It's called over diagnosis. So அவங்களுக்கு ultrasound பண்ணு, biopsy பண்ணு, அந்த anxiety cost வளர்ந்துட்டே இருக்கும். இன்னொன்னு என்னன்னா, the mammogram is not 100% full through. 10 to 20%, even as the best of cans we can miss 10%. So இந்த 5 to 7% pick up பண்ண வேண்டியதுல ஒன்று ரெண்டு விட்டுருவோம். So and then நிறைய பேருக்கு there's a false sense of security. நான் இப்பதானே மேமோகிராம் பண்ணிட்டேன், எல்லாம் நல்லா இருக்கு சொன்னாங்க. So they might even ignore a breast symptom. இப்பதானே பண்ண நல்லா இருக்கு சொன்னாங்க, அப்புறம் ஒரு கட்டி இருந்தா கூட they may ignore. So and then mammogram quality standards. So mammogram is dependent on the quality of the machine, the technology, the technologist, the one who's doing the mammogram. Are they including the entire breast in the mammogram? So breast comes in all sizes and shapes. People are all sizes and shapes. So they have to get the most optimal picture. ரெண்டாவது optimal interpretation. Whoever's reading it, are they reading it with the necessary skills? Even with the necessary skills, we can be foxed. Because it's all pattern reading, and it's like illusion. You show me 10 pictures and you pick out then the 7 changes kandupidi, 6 changes. So even the best of sharp minds will fail. We have failed. So this is possible. And then you pick up a 3 millimeter cancer or a 7 millimeter cancer. Who's going to locate it for you? You don't feel it. And then you should have the bandwidth to locate this, remove this correctly. No, I have seen people in the mari mammogram எல்லாம் பெருசில பண்ணிட்டு அப்புறம் போய் ஒரு சர்ஜன்ட்ட போனா அவங்க அப்படியே you can't blame them. Technology அங்க it does not exist. So இங்க போட்டு அங்க போட்டு குத்து மதிப்பா இங்கதான் இருக்கும்னு எடுத்து they think they've removed it, but actually it hasn't been removed. And then they come for a second opinion here. We do another examination, we find it sitting there as it was earlier. Some other part of the breast is removed. So these are all the challenges that comes with unplanned, unorganized screening. So therefore, as a rule, people like us, we are like somewhere where we are influencing decision making, we have to be careful about going in tom-tomming mammogram. So this is my bread and butter. I run a center with the mammogram machine, but I will not. But I used to earlier, but more and more I see
with the experience
and come by. You see more problems with such screening. But நம்ம நாட்டில் அதுவும் தேவைப்படுறது. Somewhere, see a bus with mammogram, there's some awareness created. Under 5 to 6 people, it may actually make a life-changing decision. So, and then there are pros and cons. So, my only request is anybody doing a program, do it with the proper systems in place, and a proper audit, proper, go back and look at your results. Go back and see, have you made a social impact? No, so சும்மா போய் நானும் பண்ணினேன்னு பண்றதுன்னு அர்த்தம் இல்ல. So that's where that population based screening where a woman does not have any symptom. So the symptom and that becomes diagnostic, is no longer screening. So screening the opportunistic. I am health conscious, I want to proactively check. I would recommend 40 years and above every 2 years. So high risk of the family history இருந்தது அப்படின்னா அவங்களுக்கு we would do a genetic counseling and advise accordingly. If they are reluctant to have genetic counseling and testing, we respect that. அவங்களுக்கு we may recommend more frequent yearly screening.
So mammogram, actually not all mammograms are equal சொன்னீங்க. அதுலேயே different categories இருக்கு, technology wise, again expense wise, எல்லாமே வந்து it is different. So அப்படி பேசும்போது now we saw a recent report which said that AI, one good thing, there are a lot of negative things which are also being said, but one good thing about AI is coming in all fields of medicine, and AI detects breast cancer about 5 years before actual onset quite reliably, that Mirai platform appdin solliட்டு.
These are definitely improvements in technology, and that's a future definitely. And the human error will, 10% error with mammogram na AI will narrow it down to 2%. That's for sure. So over a period, definitely all these things are going to, my understanding is in this next 2 to 3 years, we'll have if all the AI research is culminating now, in the next 2 to 3 years, there'll be a big boom and this complete platform will change. So that is for the good only.
Yes, certain things we have to just keep advances are good and போக வேண்டியதான். So ultrasound, you have already said, sometimes if you are வந்து diagnosing, but always வந்து mammogramமும் பண்ணி ரெண்டுத்தையும் சேர்த்து கொடுக்கறது தான் வந்து better rather than only ultrasound and சொல்லிட்டு you had mentioned. What is the role of MRI breast?
So MRI, a very selective role. High risk screening could definitely use. We use it as a problem solving tool. So sometimes, additionally we need some more information. We're a little less confident with calling it off. MRI use பண்றோம். In very dense breast, mammogram may not be very contributory. ஒரே white-ஆ தெரியும் full-ஆ breast பூரா. அதில் வந்து we may not be able to pick up. So அங்கேயும் we ask for MRI. Sometimes to plan surgery, the extent of disease. So how much more, when the DCIS component of it, how much is there in the or assessment of extent of disease. So how much to remove, how much tissue to remove, can I conserve the breast, should I do a mastectomy, அந்த மாதிரி decisions-க்கு. And sometimes the pre and post chemotherapy. So இப்போ நிறைய we use chemotherapy before surgery to reduce the size and then we have a lot of advantages for selecting that way. So அப்போ வந்து pre and post பண்ணும்போது then you, because chemotherapy shrinks the tumor, but does it shrink concentrically from periphery to center, or does it kind of, in the cheese crumble பண்ணி போட்டா the Swiss cheese appearance சொல்லுவோம். அது மாதிரி the big lump like that, does it reduce from center to periphery and then it is only this much that I remove that much, or it's reduced but it's all scattered all around. And the type of response, therapy scales are scattered all around, you have to go remove to that extent. Again, நடுவில் centripetal or then you can remove only that. The kind of pre and post chemotherapy we do the MRI.
ஸோ மேமோகிராம்ஸில் இப்போ ஸ்கேனில் வந்து கட்டி மாதிரி தெரியறது நம்மளுக்கு. மேமோகிராமில் என்ன அடிஷ்னல் இன்ஃபர்மேஷன் ஏர்லியர் ஸ்டேஜ்லேயே கண்டுபிடிக்கலான்னு சொல்லிட்டு நினைக்கிறேன்?
Sometimes small cutties that you don't feel you'll see on mammogram. And then calcifications சொல்லுவோம், micro calcifications. அப்புறம் some asymmetry. So breast is a paired organ. ஒன்று போல தான் இன்னொன்று இருக்கும். Sometimes there will be some asymmetry. Some asymmetry is physiological. But some if you see an asymmetry, physiological னு சொல்றதுக்கு முன்னாடி rule out a cancer. Now just doing mammogram பண்ணா 40 வயசுக்கு மேல தான் இருக்கும். So அந்த ஏஜ்ல there is a risk. So asymmetry ன்னு பார்த்தனா then we do an additional ultrasound. We do some additional views if needed. அப்புறம் வந்து asymmetry வந்து இது ஒன்றும் ordinary asymmetry தான், physiological, normal asymmetry. Architectural distortion. So there is a pattern to this breast. It's like, if you have a tree, அது பேட்டர்ன் இருக்கு. பொனிஃபெரஸ் ட்ரீனா ஒரு பைன் ட்ரீனா எல்லாத்துக்கும் நடுவில் எங்கேயா ஒன்று வெட்டி விட்டு இல்லை கோணெல்லாம் வளைஞ்சிருந்தது அப்படின்னா டிஸ்டார்ஷன். So something like that will happen with the breast tissue also. If there is distortion, then we probe. இங்கே ஏதாவது சர்ஜரி பண்ணாங்களா, இங்கே ஏதாவது இன்ஃபெக்ஷன் ஆச்சா, எதனால ஆச்சு இல்லை அப்படின்னா then could it be some abnormal cells growing there that is distorting the breast. இதெல்லாம் கைக்கு தெரியாம இருக்கும். Some of these may not even be seen on ultrasound, like a microcalcification you can't see.
What are these microcalcifications?
So microcalcification basically, and the duct in சொல்றேன் இல்லையா, and the milk ducts that conducts the milk to the nipple area. And the milk ducts it is lined by one layer of epithelium. It's like if you can imagine plumbing tube, hose pipe. அந்த ஹோஸ் பைப்ல உள்ளுக்குள்ள ஒரு லேயர் ஆஃப் epithelial cells இருக்கும். சப்போஸ் இட் டெவலப்ஸ் a cancer, அந்த epithelial cells இருந்து தான் ஆரிஜினேட்டா. அந்த epithelial cells multiply in number and grow disproportionately. So it will fill the duct.
Okay.
So the cancer cells also need oxygen and glucose to survive. So ஒரு 2 millimeter levelக்கு அந்த oxygen diffuses and glucose comes and it reaches and the cell is alive. So it goes beyond that. Within the duct there is no access to blood supply. So those cells, what happens? It dies.
Okay.
So any dead tissue, what will happen? Calcium will deposit.
Okay.
So அதுதான் microcalcification சொல்றோம். அந்த calcification we do some pattern reading.
Okay.
And the calcification or the morphology, does it look rounded? Does it look smooth? Does it look jagged? Does it look irregular? Like ஏதோ ஸ்டோனை வந்து நம்ம கட் பண்ணா uneven particles அந்த மாதிரி இருக்கா? அப்புறம் is it casting itself like along the duct? அந்த டக்டுக்குள்ளர வளருது என்ன ஆகும்? டக்டுக்குள்ளேயே வளர்ந்து அப்ப அந்த டக்ட் ஷேப்புக்கு அந்த லெங்க்தியா இருக்கும். linear calcification. So we do some patterns reading to know, judge the level of suspicion to biopsy or non-biopsy. And that's how we do calcification. Some of these tumors are secretory.
Okay.
When it produces the fluid, and the fluid on the stagnates, petrifies. Like, you have only stalactites, stalagmites. There's too fluid on the petrifies there at that point, and that also calcifies.
Okay.
Adil irukra and the calcium content deposits there, and so these are different forms of calcification,
which we see on the mammogram only and not on the ultrasound. Okay. So when you were talking about biopsy, there are different kinds இல்லையா? ஒன்று வந்து நம்ம ஓபியாவே, again everything is done OPA as a OP procedure, but FNACன்னு சொல்லிட்டு fine needle aspiration cytologyன்னு வெறும் fluid எடுக்கிறாங்க. சிலது வந்து core needle biopsyன்னு, which is what I had done with you அப்படின்னு scan guidedவே you are putting in and removing a core of solid tissue actually அப்படின்ட்டுன்னு. So which for which அப்படின்னு நினைப்பீங்க?
FNAC we stopped doing. I don't think anyone should do anymore.
Okay. Even for a fibroadenoma?
Yeah. So you see, you ask a pathologist or a cytologist. When pathologist is more happy to see more tissue than few cells here and there started, and then challenge them to give a diagnosis. Okay. So FNAC la non-diagnostic samples are very common. நம்ம எடுத்து கொடுப்போம், அது ஒண்ணுமே தெரியலன்னுவாங்க. These are non-diagnostic samples. So you poke somebody. Actually, to tell you the truth, FNAC is more painful than core biopsy.
Okay.
இந்த வந்து சின்ன நீடில் தானே லோக்கல் கொடுக்காம பண்ணுவாங்க. அது பண்ணும்போது then you go back and forth. It's actually more painful. And slides பார்த்து இன்னும் வேணும் திருப்பி ஒரு தரம் கொடுப்பீங்க. And if you see core biopsy, we give local, make a small nick and do. It's a controlled procedure, like a tooth extraction.
Okay.
Initial biopsy தான், அப்புறம் ஒன்றும் இல்லை. ஸோ இங்கே வந்து FNAC நான்-டயக்னாஸ்டிக் சாம்பிள். ரெண்டாவது ஃபால்ஸ் பாசிட்டிவ் விட ஃபால்ஸ் நெகட்டிவ் ஆகும் டேஞ்சரஸ். நான் கான்ட்ரிபியூட்டரி ஆஃப் ஃபால்ஸ் நெகட்டிவ். அப்போ என்ன பண்ணுவோம்? இப்போ ரெஃபரிங் டாக்டர் பார்த்துட்டோம், அதை பண்ணோம் அது ஒன்றும் தெரியல அப்படின்னு they close the case and reassure the lady. And she goes back thinking, okay, test பண்ணி பார்த்துட்டோம் நெகட்டிவ். பாசிட்டிவ் சொன்னா ஃபால்ஸ் பாசிட்டிவா இருந்தா கூட பாசிட்டிவ்னா விடமாட்டாங்க. இன்னொரு டாக்டர் ஒப்பீனியன் போவாங்க, இன்னொரு கிராஸ் செக் பண்ணுவாங்க. they do something about it. நெகட்டிவ் சொன்னா they want to put it aside. And this is a provider challenge. They're going to add 6 months later they will have a bigger tumor. கிளாசிக்கல் இஸ் நான் போனேன் டாக்டர், நான் 2 தரம் பார்த்தேன் டாக்டர், இதெல்லாம் FNAC பண்ணிட்டு ஒன்றும் இல்லைன்னு சொல்லிட்டாங்க டாக்டர் அப்படின்னாங்க. So that way core is important, and we clearly said no, ultrasound guided. And the core வந்து it has to be a guided procedure. Why guided? Because நாம வந்து கட்டிக்குள்ள போகுது நீடில் நினைச்சுட்டு இருக்கோம், but needle may actually not traverse the டியூமருக்குள்ள போகாம டியூமர் பக்கத்துல இருக்கிற நார்மல் பிரெஸ்ட் டிஷ்யூ போச்சுன்னா you will get a negative biopsy. You get a normal breast tissue. அப்புறம் அங்கேயும் ஃபால்ஸ் நெகட்டிவ்ஸ் ஆர் பாசிட்டிவ். Okay. And image guidance இருந்ததுன்னா you are seeing on the ultrasound screen, நமக்கு இதை வச்சு பார்த்துட்டே இருக்கோம், நீடில் உள்ள டியூமர் உள்ள போறதா இல்லையா, are we taking the right representative sample? This is very important. We always do நல்லா பெருசா கட்டி இருந்தா கூட I still prefer to put a probe, screen and then do a biopsy. And core any day, I think it's the standard procedure across
all age groups also, ma'am.
Across all age. Okay. If you have to do a sample, might as well give a good nice chunk of sample for the pathologist to tell confidently than a little bit of like fluid
So, okay. So, I think I am changing a lot of what I have thought and will carry forward in my own practice, which has proven very eye-opening for me, Nanikram, because I have not stayed updated with the current screening and so many things to do with the breast because it is not really my specialty as such. So, it has been wonderful to learn a lot of stuff, I would say. So, what are the common types of breast cancer? Breast cancer liye different types irka ma'am, and ellarkum pudiyum padi staging அப்படினு நம்ம சொல்லணும். early stage, late stage, advanced, locally advanced. So, அது புரியும் படி what are the different stages and why is it important? Because prognosis and survival rates depend on them, இல்லையா?
ஸோ இந்த டைப்ஸ்ன்னு பார்த்தா அது ப்ராட்லி ஃபர்ஸ்ட் வந்து இன்சிட்டூன்னு சொல்லுவோம். இன்சிட்டூ இஸ் பரவாம இருக்கக்கூடியது, அங்க மாத்திரம்தான் இருக்கு, வேற எங்கேயும் பரவல. இந்த டக்டுக்குள்ளர வளர்ந்ததுன்னு சொல்றோம் இல்லையா, இந்த மில்க் டக்டுக்குள்ளர அங்க மாத்திரம் இருக்கு, இன்னும் மில்க் டக்டோட வால்ஸை பிரீச் பண்ணி வெளியில வரல அப்படிங்கிற டைப் எல்லாம் we call it in situ cancer. These are generally stage 0 breast cancer சொல்லுவோம். These are most of these are completely curable and பெருசா அந்த மேஜர் ட்ரீட்மெண்ட்ஸ் லைக் கீமோதெரப்பிலாம் அதுக்கு தேவைப்படாது. So that's one group of tumors. இன்னொரு குரூப் ஆஃப் டியூமர்ஸ் இஸ் இன்வேசிவ். வேர் இன்வேசிவ்னா இந்த டக்டனுடைய பேஸ்மெண்ட் மெம்பரை பிரீச் பண்ணி அதை தாண்டி வெளியில வந்துருச்சு அப்படின்னாலே வி கால் இட் இன்வேசிவ். அந்த இன்வேசிவ்ல ப்ராட்லி வந்து நாட் அதர்வைஸ் ஸ்பெசிஃபைடுன்னு சொல்லுவோம். அப்படின்னா அது ஒரு பர்டிகுலர் குரூப்ல எங்களால போட முடியல அப்படிங்கறதெல்லாம் ஒரு செக்மெண்ட். அது வந்து அக்கௌண்ட்ஸ் ஃபார் அபவுட் 60-70% ஆஃப் பிரெஸ்ட் கேன்சர். அவன் ஒரு பேர் எடுத்தோன்னா ஒரு 60-70 பேர் வந்து இன்வேசிவ் வந்து நாட் அதர்வைஸ் ஸ்பெசிஃபைட், ஒரு குரூப்ல ஒரு கேட்டகரியில அதை ஃபிட் பண்ண முடியல அப்படிங்கிறது தான் காமன். அப்புறம் இந்த கேட்டகரியில ஃபிட் பண்றது என்ன பாத்தீங்கன்னா ஸ்பெசிஃபைட் டைப்ஸ்ன்னு சொல்லுவோம். அது வந்து மியூசினஸ், மியூசின் செக்ரேட்டிங் டியூமர். இந்த சளி மாதிரி அந்த டியூமர் வில் செக்ரேட் தட் ஃப்ளூயிட். அதனால கட்டி பெருசா தெரியும். But these tumors are very good tumors. They are good prognostic tumors. They are usually low grade and curable tumors in the mucinous. அடுத்தது பார்த்தீங்கன்னா papillary. Papillary தான் அந்த சிஸ்ட் மாதிரி நீர் கட்டி மாதிரி இருக்கும். உள்ளுக்குள்ள it will grow within, it will secrete a lot of fluid. இதுவும் generally கட்டி சைஸ் பெருசா இருந்தா கூட these are generally கொஞ்சம் slightly innocent tumors and prognostically நல்ல tumors. They do very well. Okay. அப்புறம் there is something called மெட்டபிளாஸ்டிக் டியூமர்ஸ். இது கொஞ்சம் அக்ரெசிவ் டைப். இது வந்து வேரியஸ் காம்பனன்ட்ஸ் ஆர் தேர் அண்ட் இது கொஞ்சம் அக்ரெசிவா ட்ரீட் பண்ணுவோம். அப்புறம் மெடுலரி கேன்சர், இது வந்து யங் பீப்புளுக்கு வரும். மோர் அந்த ஹெரிடிட்டரி டைப் கேன்சரோட அசோசியேஷன் நிறையா இருக்கும். இதுக்கும் ஆக்சுவலி அக்ரெசிவா இருந்தா கூட நல்ல சீக்கிரம் கண்டுபிடிச்சி ட்ரீட் பண்ணிட்டா they do long term prognosis actually very good. ஸோ மெடுலரி ஒரு டைப்பு. அப்புறம் டியூபுலர் கேன்சர் சொல்லுவாங்க. இதுவும் ஒரு இன்னசென்ட் டைப் கேன்சர். இதுவும் வந்து இருக்கேன்னு இருந்துகிட்டே இருக்கும். பேசிக்லி நாட் வெரி லைஃப் த்ரெட்னிங். ட்ரீட் பண்ணிட்டா இட் இஸ் கியூரபிள் அண்ட் கம்ப்ளீட்லி தே டூ வெல். ஸோ இதெல்லாம் வந்து ஸ்பெசிஃபைட் டைப்ஸ். அப்புறம் இன்னொரு வெரைட்டி லாபிலன்னு சொல்லி, இதெல்லாம் வந்து டக்டில். டக்டில்னா டக்டுக்குள்ள மில்க் டக்டிலேருந்து வருது. ஓகே. அப்புறம் இது வந்து டக்டில் கேன்சர்ஸ் அக்கௌண்ட் ஃபார் அபவுட் 80-90% ஆஃப் ஆல் கேன்சர்ஸ். ஒரு 10% வந்து லாபிலர்ங்கிறது அந்த டிடிஎல்யூல இருந்து வருது. லாபியூல் ஆஃப் த பிரெஸ்ட் அவே ஃப்ரம் த டக்ட். ஸோ இது வந்து திஸ் இஸ் பிட் சேலஞ்சிங் பிகாஸ் தீஸ் ஆர் டிஃபிகல்ட் டு டயக்னோஸ். இது வந்து அப்படியே அந்த க்ரீப் ஆயிட்டு இட் க்ரோ. ஸோ எல்லாரும் கூட்டமா நின்று ஈஸியாக கண்டுபிடிச்சிடலாம். பட் அப்படியே ஒன்று பின்னாடி போனோம் சீரியஸா நின்றுட்டு இருந்தாங்கன்னா நம்ம முதல்ல பாக்குறவங்க முதல்ல நிக்கிறவங்க தான் தெரியும், பின்னாடி இருக்கவங்கலாம் தெரிய மாட்டாங்க. ஒருத்தம் தான் இருக்கான்னு நினைச்சுட்டு இருப்போம், பட் ஆக்சுவலி தெல் பி லாட் மோர். So அதுதான் lobular cancer. It is a nightmare to detect. To detect. Treatment is the same. Okay. Detect is a problem. So இதுதான் types of breast cancer. Okay. So one more way we types classify பண்றது more like biologically we say now hormone dependent breast cancers, ER/PR positive. நம்ம உடம்புல லேடிஸ்க்கு ஈஸ்ட்ரஜன் ப்ரொஜெஸ்டரான்ங்கிற ஹார்மோன் இருக்கு. இந்த ஹார்மோன் தூண்டுதல்னாலேயோ ஃபெசிலிட்டேட் பண்றதுனாலயோ வளரக்கூடிய டியூமரை ஹார்மோன் டிபெண்டன்ட் டியூமர் சொல்லணும். அப்புறம் இன்னொரு பிக் டிரைவர் ஃபார் பிரெஸ்ட் கேன்சர் இஸ் HER2 பாசிட்டிவ் பிரெஸ்ட் கேன்சர். இந்த HER2ங்கிறது இஸ் அ கைண்ட் ஆஃப் ஆங்கோ ப்ரோட்டீன். இது எல்லாத்துக்கும் இருக்கும் நார்மலி, பட் இட் இஸ் ஓவர் எக்ஸ்பிரஸ்ட் இன் சம் கேன்சர்ஸ். இப்போ 100 கேன்சர் எடுத்தோன்னா ஒரு 30 பேர்த்துக்கு இட் பி ஓவர் எக்ஸ்பிரஸ்ட். நிறைய இருக்கு. அப்போ அது வந்து ஆக்ட்ஸ் லைக் ஆக்சிலரேட்டர். ஒரு மிஷினை போட்டு ஆன் பண்ணி ப்ரெஸ் பண்ணா எப்படி வேகமா வண்டி போகுமோ அது மாதிரி இந்த செல்ஸ் டிவைட் அங்குறோ. அது வந்து HER2 பாசிட்டிவ் பிரெஸ்ட் கேன்சர். இதுல என்ன ஒரு அட்வான்டேஜ்னா HER2 பாசிட்டிவ் பிரெஸ்ட் கேன்சருக்கு although it's seemingly aggressive because it divides and grows more, HER2 positive breast cancer ஒரு டார்கெட்டட் ட்ரீட்மெண்ட் இருக்கு. ஜென்ரலா பொதுவா இங்க இருப்பேன் அடிக்கிறத விட்டுட்டு இங்கதான் இருக்க ஒன்னு அடிக்கிறேன் பாருன்னு அடிக்கிறது டார்கெட்டட் breast cancer. ஓகே, அது வந்து இந்த HER2 positive is very very effective and that's actually the single most important revolution that's happened in breast cancer management and the HER2 positive breast cancer treatment. அப்புறம் there is one where we say triple negative, மூணுமே நெகட்டிவ், ER நெகட்டிவ், PR நெகட்டிவ், ட்ரிபிள் நெகட்டிவ். இந்த ட்ரிபிள் நெகட்டிவ்ஸ் are a bit of a challenge because அவங்களுக்கு ஹார்மோன் தெரப்பி வேலை பண்ணாது, ER டைரக்டட் ட்ரீட்மெண்ட் கொடுக்க முடியாது, HER2 டைரக்டட் ட்ரீட்மெண்ட் கொடுக்க முடியாது. ஸோ you have to only chemotherapy. So means apart from surgery, radiotherapy, chemotherapy. இப்போ கொஞ்சம் அதுக்கும் இம்யூனோஸ் எல்லாம் இருக்கு. அந்த பெம்ப்ரோன்னு ஒரு ட்ரக் இருக்கு, அதையும் இம்யூனோஸ் அதுக்கும் யூஸ் பண்றோம். பட் இந்த இந்த ட்ரிபிள் நெகட்டிவ்ஸ் கொஞ்சம் there is a slight அந்த ஹெரிடிட்ரியோட அசோசியேட் ஆயிருக்காங்க நிறைய. ஸோ இந்த ட்ரிபிள் நெகட்டிவ்ஸ் வந்து இனிஷியலி they do கொஞ்சம் ரெக்கர் ஆகல இந்த ஃபர்ஸ்ட் 2-3 years, அப்புறம் லாங் டேர்ம் they do very well. But the initial recurrence is slightly on the higher side.
Actually, I had a very, very close family friend whom we lost to breast cancer. So she was living in Australia. So அவங்களுக்கு வந்துட்டு early stageல கண்டுபிடிச்சிட்டாங்க, lumpectomy தான் பண்ணாங்க. And she underwent chemo, everything. She was cancer free for about nearly 3 to 4 years in between everything. So she was out of the woods. But when the recurrence came again, it was a triple negative breast cancer. And she had liver meds, she underwent a partial hepatectomy, and she fought valiantly. I mean, she was very positive going to work between her chemotherapy cycles, and she underwent and did everything, but unfortunately she lost the battle, I will say. So usually triple negative is the...
It's like there's a lot of good about it and there's some negative also about it. And again, எல்லாமே வந்து it's like the bell curve, no? Many fall under that one big thing. And there are outliers. Okay. So generally, இந்த கூகுள் பண்ணா ட்ரிபிள் நெகட்டிவ்லாம் பேட் யாரும் and எல்லாம் பயந்துருவாங்க. Yes. But triple negatives who do extremely well also. Okay. So there's one segment who do recover very quickly. There's one segment who don't. Okay. So sometimes it's difficult to categorize into different groups, but that is why we follow up.
ஸோ ட்ரிபிள் நெகட்டிவ்னாலே பயந்துடணும்னு சொல்லிட்டு அவசியம் கிடையாது. இட்ஸ் நாட் ஒன் சைஸ் ஃபிட்ஸ் ஆல் அண்ட் இட் இஸ் வெரி இண்டிவிஜுவலைஸ்ட் அண்ட் ஸோ தட் இஸ் அ குட் திங் பீப்புள் ஷுட் டேக்னு நினைக்கிறேன்.
ஸ்டேஜிங் வந்து it depends. So the classical staging we say is depends on the tumor size, depends on the nodes, அப்புறம் மெட்ஸ் எங்கேயும் வேற எங்கேயும் பரவிருக்காங்க. இந்த breastல இருக்கிற கட்டினுடைய அளவு, so this is less than 2 centimeters, 2 to 5 centimeters, more than 5 centimeters, skin involved or not, அதெல்லாம் ஒரு ஸ்டேஜ் டிஃபர்மேஷன் கேட்டகரி. அப்புறம் லிம்ஃப் நோட்ஸ், இப்போ வந்து வாயிலெல்லாம் புண்ணு வந்தா, தொண்டையில எதுவும் ஃபெரிஞ்சைட்டிஸ் டான்சில்லாம் இருந்தா இங்க வந்து கழுத்துல நெறி வருது, ஏரியா கிளான்ஸ், அது மாதிரி டியூமருக்கும் நெறி கட்டும். ஜென்ரலி இந்த அக்கில்ல ஆம்பிட்ல தான் நெறி கட்டும், லிம்ஃப் நோட்ஸ்னு சொல்லுவோம். ஸோ அதுல பரவிருக்கா இல்லையாங்கிறது இட்ஸ் அன் இம்பார்ட்டன்ட் ஸ்டேஜிங் இன்ஃபர்மேஷன். ஸோ அதையும் பார்ப்போம். ஸோ அதை வச்சுட்டு தென் த குரூப்ஸ் பண்ணி ஸ்டேஜ் 1னா லிம்ஃப் நோடுக்கு பரவல கட்டி லிமிட்டட் டு 2 centimeters. ஸ்டேஜ் 2னா அதுலயும் ஏபின்னு வச்சுப்போம், லிம்ஃப் நோடுக்கு பரவாது பட் ஸ்லைட்லி மோர் தென் 2 centimeter. பினா லிம்ஃப் நோடுக்கு பரவி இருக்கு. 3னா மோர் தென் 5 centimeters, அதுலயும் லிம்ஃப் நோட்ல இருக்கா இல்லையா. 4னா ஸ்ப்ரெட் டு அதர் ஆர்கன்ஸ். ஸோ ரஃப்லி ஜென்ரலி ஸ்டேஜ் 1 and 2 technically by the book they should do well. 3 and 4 prognosis a little guarded. Okay. அதுல இந்த இப்போ வந்து அந்த ஸ்டேஜ் வெறும் கோயிங் பை த நம்பர் ஆஃப் நோட்ஸோ size of the tumor விட the biology we have to respect. அந்த biology தான் அந்த ER/PR, HER2, KISI7 ஃபேக்டர். ஸோ இப்போ நான் ஸ்டேஜிங் இன்ஃபர்மேஷன் மாத்திரம் வச்சுக்கிட்டு ப்ரோக்னோஸ் சொல்றதை விட அதையும் இன்க்ளூட் பண்ணி அப்புறமா ப்ரோக்னோசிஸ் சொல்றது பெட்டர். லைக் ஐ செட் there are always outliers in any group. இதுல வந்து ஒன் சைஸ் ஃபிட்ஸ் ஆல்னு ஒரே மாதிரி எல்லாருக்கும் நம்ம சொல்ல முடியாது.
ஓகே, but again breast cancer in today's day and age is highly treatable with a lot of options. And கேன்சர்னாலே பயம்தான். கேன்சரே வந்து இட்ஸ் அ டிஃபிகல்ட் டிசீஸ் ஃபார் த ஹோல் ஃபேமிலி, நாட் ஒன்லி ஃபார் த பேஷண்ட். But again, out of the so many other cancers which have a poor prognosis, breast cancer, especially if detected early is definitely treatable and even curable, and that's why I think we should all be vigilant in checking something which is easily நம்மளே வீட்டில் செக் பண்ணலாங்கிறது நம்ம விட்டுறக்கூடாதுன்னு நினைப்பேன். ஸோ நம்ம இப்போ கண்டுபிடிச்சிட்டோம் ஸ்டேஜ் என்னன்ட்டுன்னு, டைப் ஆஃப் breast cancer நீங்கள் பயாப்சி பண்ணி சொல்லிட்டீங்க. ஸோ வாட் ஆர் த ட்ரீட்மெண்ட் ஆப்ஷன்ஸ் which you would offer the patient in short, ma'am?
So again, it depends on biology. So we always do on the ER/PR and HER2 tests before we decide any treatment plan. ER/PR positive, HER2 negative அப்படின்னா ஆப்ரேட் ஃபர்ஸ்ட். அதில் ஸோ அது சர்ஜரி எப்படிங்கிறது அப்புறமா சொல்லுங்கள். இப்போ ட்ரிபிள் நெகட்டிவ் அண்ட் HER2 பாசிட்டிவ் அப்படின்னா டெஃபினெட்லி நோட் பாசிட்டிவ், ஸ்லைட்லி யங்கர் பர்சன் அப்படின்னா டெஃபினெட்லி வி கிவ் தம் chemo first. Chemo and targeted therapy first and then only operate. So இப்போ எடுத்தோடனே jump and operateங்கிற கான்செப்ட் போயிடுச்சு. Most of these diseases are now medically managed before they come to surgery. Whereas ER/PR positive or to negative, upfront surgery. So this is how we plan. And the surgery வந்து அந்த conservative option, breast preserve பண்ணக்கூடிய option versus full removal. On the options that we'll discuss, that will depend on the size of the breast, location of the tumor, ptosis on the droop of the breast. Okay. Or the density of the breast. Now, breast is more fat or more fibroglandular tissue, age. What her respect also, her wishes also, we respect that. Some people say, I want to go flat. Yeah. And we're very keen that I want to remove it. And some people will say, at any cost, don't remove, do anything but remove. Oh. So idellame we factor it in. Definitely. And then decide, take a call. Apart from breast surgery, at the time of surgery, we also do a nodal assessment. So node வந்து அந்த diagnostic processலயே we do a nodal evaluation. Ultrasound பண்ணி பார்ப்போம், தேவைப்பட்ட ultrasound guided nodal sampling பண்ணுவோம். So this is a situation where FNAC can be used. Node, although we are kind of, skill sets are different and we do a core itself. But there are here is a situation where FNAC can be applied, not for breast but for nodes. Okay. So இது பண்ணும்போது you get the nodal staging then itself. Okay. After surgery பண்ணும்போது we do a procedure called sentinel lymph node biopsy. Here we actually use a dye radioisotope and then pick out the first level of lymph nodes. So as the name suggests, sentinel na guard. So இப்போ நம்ம இந்த காம்ப்ளெக்ஸில் வாசலில் ஒரு செக்யூரிட்டி இருப்பான். If that security guard is safe there and he's standing happily, then all of us inside are safe. But அவன் ஒரு டெரரிஸ்ட் வர அவனை சுட்டு போட்டான்னா then next target will be us. Yes. So our job as surgeons is to pick that first one. So how do we identify? We use colored dyes, we use radioisotope. அது அந்த lymphatic channels வழியாக போய் அந்த first level of nodesல போய் உட்காரும். It will stay in blue, it will pick up radioactivity. We take that out, send it for frozen section to the pathologist. While they do that, we finish the rest of the procedure. If they say nodes are involved, then we go and clear. Okay. If they say nodes are not involved, then we leave it. But if we don't go there, the risk of lymphedema is less. You don't unnecessarily go and remove everything for everybody.
ஸோ எல்லாத்தையும் ரிமூவ் பண்ணோன்னா லிம்ஃபடிமா இது பிரெஸ்ட் கேன்சர் சர்வைவர்ஸ் எல்லாரும் அண்ட் ப்ரீவியஸ்லி நிறைய பேர் இப்போ பிரெஸ்ட் கன்சர்வேஷனுங்கிறது ரீசெண்ட் முன்னாடிலாம் ஐ திங்க் இட் வாஸ் மோர் கிளியரன்ஸ் வந்து மாஸ்டெக்டமி தான் பண்ணுறாங்கன்னா லிம்ஃப் நோட் கிளியரன்ஸும் கொடுக்கும்போது அந்த கை வீக்கம் இல்லையா மேம்?
மாஸ்டெக்டமிக்கும் சென்டினல் பண்ணலாம். ஓகே. மாஸ்டெக்டமி ஆல்சோ கேன் பி கம்பைன் வித் சென்டினல். only if it is involved we clear. இப்போலாம் வந்து கன்சர்வேஷன் பண்ணும்போது even if it's involved we now actually select patients to clear. So அப்போ வந்து NP radiation கொடுக்க போகிறோம் breastக்கு. So give radiation to the axilla, then you don't actually do two procedures which will harm the increase the risk of lymphedema. And the outcomes are definitely equal in terms of survival and disease.
Lymphedema என்ன just for?
Lymphங்கிறது it's a fluid like you have blood circulation, you have a parallel circulatory system called lymphatic system. Lymphங்கிறது ஒரு fluid, like for lay people I'm explaining. இந்த lymph fluid வந்து it all drains into the mixes with the thoracic duct மூலமா into the blood circulation and gets filtered and it has one parallel circulatory system. இப்போ the lymph fluid வந்து actually carries all the nutrients also and all the bacteria. Suppose you have one இப்போ வாயில் புண்ணு இருக்குன்னு வச்சுக்கோங்க, அந்த புண்ணு வழியா அந்த அல்சர் வழியா வாயில் இருக்க bacteria will enter. That bacteria enters through the circulation and it goes to imagine through the heart it goes to all organism, we'll develop sepsis. So இந்த lymph fluid என்ன பண்ணும், அந்த lymph fluid அந்த lymph nodeல இந்த bacteria filter பண்ணி அந்த இடத்துல it will destroy the bacteria. So each of the lymph nodes are defense mechanisms for us, like you know, நம்ம security systems. So in the like it filters the bacteria, it will also receive the tumor cell and let it grow there.
Okay.
அப்ப அதைத்தான் நம்ம இன்வால்வ்மெண்ட் சொல்லி செக் பண்றோம். So tumor இருந்தா we clear it off because அங்க இருந்து it keep throwing cells everywhere.
Okay.
We clear it off. Cancer control is important, no?
Yeah.
We take it off. But அப்போ என்ன ஆகும், அந்த lymph node junctions we are disrupting. So like you know, imagine a railway station. So there is trains coming from one junction, say Arakonam junction to Central, and from there they have to go to Renugunda. So இங்க வந்து அரக்கோணம்லயே block ஆயிடுதுன்னு வச்சுக்கோங்க, and the train is not coming here, then all the passengers are stranded at Arakonam because they're not able to move forward. அது மாதிரி all the lymph fluid which is supposed to drain into the lymph node is taken off the lymph node because you want to clear cancer. அந்த cancer எடுத்துட்டோம்னா இவங்க எல்லாம் they are getting stranded. So அப்ப fluid circulation இல்ல, அப்ப என்ன ஆகும், வீங்க செய்யும். So you have to develop collaterals, and the collaterals may not be enough. Collaterals get damaged when you have recurrent infections, and the thicker the arm becomes more because it constant ஒரு all the fluid எல்லாம் fight and infections fight பண்றதுக்கு lymph node இல்ல. So the little bacteria இருந்துட்டே இருக்கும் அந்த ஆம்ல. So little bit of cellulitis, அப்புறம் that causes local tissue reaction and fibrosis, and because there is fibrosis there is still less movement. So wingy. So that is why anywhere where do we do a clearance, we give them a set of rules. Don't cut decently with a nail cutter. Don't do this chewing and all. Don't do any job that will harm the skin. Like gardening na glove போட்டு பண்ண kitchen la, be careful with your cutting equipments. ஓடு வச்சுக்காதீங்க. இந்த பக்கம் blood pressure check பண்ண வேணாம், because when you raise the pressure up to 180 to 100, you're disrupting all those delicate lymphatic vessels. அந்த side blood tests எல்லாம் தேவைப்படாம சும்மா எடுக்க வேண்டாம், எல்லாம் அந்த அடுத்த கை யூஸ் பண்ணுங்க. So these are some instructions. So அப்புறம் exercise சொல்லி தருவோம். No, the more muscles you use in the arm, then the collaterals will develop. Okay. Like you know, muscles have that contractility feature. You use that and you contract, you're milking that fluid. And then konjam தேவைப்பட்ட the sub procedure called manual lymphatic drainage. So the therapist can do, they can be taught to them also. அப்புறம் அதுக்கு மீறி lymphedema போனா some sleeves. The sleeves போட்டுக்கிறதுல கொஞ்சம் கேர்ஃபுல்லா இருக்கணும், because sleeves சரியா போட்டுக்கலன்னா அதுவே it will become like bite areas, and wherever it binds அதுக்கு மேல நிறைய திருப்பி fluid collect ஆயிடும். அப்புறம் there's another level of treatment where we use lymphapress and the pneumatic compression. கையை வந்து அதுல ஒரு ஸ்லீவ் மாதிரி விட்டுட்டு கொஞ்சம் உட்காந்து some music or do something, it massages for you. So it kind of gently pushes the fluid, but that's the last stage. We don't like to use it early on because it becomes a habit and then you can't live without it. Madri I don't. So these are the stages how we manage it.
Yeah, my aunt is suffering from that actually, because more than everything she's like, I'm trying everything but அந்த கை வீக்கம் மட்டும் போவே மாட்டேங்கிறது அப்படின்ட்டு. Okay, thank you ma'am. So we were talking about surgery. You said breast conservation and sentinel node biopsy. அதுக்கப்புறம் வந்துட்டு again அதுதான் chemotherapy, radiotherapy, other two. Surgery. So other than surgery, what are the other options will be? I think chemotherapy and radiotherapy இல்லையா ma'am, as any cancer.
Adjunct. So they are not surgery. Still much as new drugs keeps coming, surgery is the curative option.
Okay.
And this surgery, systemic therapy plays an important role, in fact a very important role, but it's still considered adjunctive. Either adjunctive before surgery where we call neo-adjuvant, or adjunctive after surgery where it's called adjuvant. The surgery center. And the surgery is essential in most curable breast cancer. Stage 1, 2, 3 surgery is definitely indicated. முன்னாடி கொடுக்கறதா அப்புறமா கொடுக்கறமாங்கிற சீக்வன்சிங் தான் depends on the biology and the stage of the disease. So chemotherapy-ங்கிறது there are some, basically it is cytotoxic. So there is some unwanted cells that are growing in the body. the unwanted cells are அழிக்கணும். Your own defense system is not working. It is not recognized it as something that is not good for our body. And the body is producing the cells. So it's actually not foreign. It is your own cell gone rogue.
Okay.
But the body's immune system is capable of recognizing and eliminating it. But somewhere we've messed it up or whatever, it's gone beyond that. And it's growing more, then we have to give something external to blast it. Other than the chemotherapeutic agents. So the chemotherapeutic agents unfortunately are not selective. Correct-ஆ போய் அதை மாத்திரம் அழிப்பேன், மற்றதெல்லாம் ஸ்பேர் பண்ணிடுவேன்னு பண்ணாது. So generally all rapidly dividing tissues get affected. So what are all the rapidly, we see physically, என்ன வளர்றது, நமக்கு hair வளர்றது, nails வளர்றது, these are all rapidly growing. And intestinal tissues, they get replenished every week. All the lining of our gut mucosa. Your bone marrow, every week it gets replenished. New cells keep forming. So இதெல்லாம் affect ஆகும். So the side effects are pertaining to that. Hair loss, nails கருக்கிறது, vomiting, diarrhea, அப்புறம் bone marrow suppression, neutropenia, all related to the drug causing that effect. The good thing is that the normal structures have the capacity to come back normal. Whereas tumor it's new, it's trying to figure out. And so you hit it gets a hit. Normal tissues recover. This does not. It takes a little bit more time to figure out what's happening. By the time it figures out, you get one more hit.
Okay.
And the 3 weeks gap is for your normal cells to recover. And the normal cells for the recover are not ready. Repeated cycles the cancer cells die.
Okay.
And therefore it causes a shrinkage of the tumor. And whatever micro metastasis, the clones of cells that are circulating, which we cannot quantify, circulating tumor cells, இதுதான் it causes damage. இங்க இருக்கிறது அது பாட்டு உட்கார்ந்துருக்கும். But some resistant clones, some cells which circulate and then lodges, அதுக்கு தோதுப்படுறப்போ அப்ப தெரியாது, நம்ம பெட் பண்ணும்போது தெரியாது, நம்ம sometimes it lodges itself in organs like liver, lung at a later date. அப்ப நம்ம seeds எல்லாம் படிக்கிறோம்ல, ஜெர்மினேஷன் என்ன, காத்துல அடிச்சுட்டு போயிட்டு எங்கேயோ போய் விழுந்து முளைக்கும், தண்ணியில் அடிச்சுட்டு போயிட்டு எங்கேயோ போய் விழுந்து முளைக்கும், ஏதாவது மிருகம் பறவை சாப்பிட்டுட்டு போயிட்டு அது போய் கழிக்கும், அங்க முளைக்கும். அது மாதிரி seed and soil theory, somewhere it seeds itself and grows, that becomes life threatening. Because breastல இருக்கிறது, breast is not a life sustaining organ. அதை வச்சுட்டு ஹார்ட் பீட் பண்றது இல்லை, அதை வச்சுட்டு உயிரெடுக்கிறது இல்லை. It's more like its function is to feed a baby, that's done. But liver or lung or damage, we cannot live.
Yes.
So that is where the damage comes. So the chemotherapy, hormone therapy is intended to destroy those cells that can potentially go and damage liver. The cause causes trouble in future. Somewhere we are not able to filter out which one responds, which one, right now,
But I think even now, chemotherapy wise, I mean, it has its side effects, but as you said, it is very horrible sometimes, definitely very toxic.
Survival.
And but it improves survival, and அந்த நேரத்துக்கு கஷ்டப்பட்டுட்டு then all these changes sort of you do get over them, so we just have to grit through it.
Most symptoms are temporary. Hair will grow back, everything will become normal. Some of them, the neuropathy da konja troublesome, one of the drugs. So adellame actually lot of things are there, like supportive things that are there. And actually it's overall, I think we should focus on rehabilitation and lifestyle correction and what we can do to live most optimally during and after all these treatments.
So adella namba patient counsel panni da what are the changes you will expect and everything, and I'm sure you will take them through it before actually giving them all those medicines.
It's very hard for them, very hard for us also. And too many changes implemented in a short period when they're already you can only handle so many challenges at one time.
Yes.
ஒரு சைடு ட்ரீட்மெண்ட் கொடுக்குறோம், அடிக்கிறோம், இன்னொரு சைடு நீ இதை சாப்பிடாத, அதை பண்ணாத, இதை பண்ண. It's so difficult actually, so unfortunate, but people get there eventually.
Yes, that's what you should give them hope and light at the end of the tunnel, that you will get through it eventually. And even though it's like horrible to go through that period, this is for the greater good, and so later we have to just keep going on.
Adila the targeted therapies have an advantage because the selective target panni adikradnala that there's a lot of sparing of other tissues, but targeted therapies generally are used along with chemo at least for a duration of time. அப்புறமா it's used separately, independently. So the targeted treatment is generally given over a prolonged period, over a year or longer. So, but a combination of all this has really impacted, and what used to be a very high mortality has now become like, not all breast cancer patients have mortality. Many of them do well. So survival rates are very good.
Very good with all the advances. Though, yes, அந்த நேரத்துக்கு கஷ்டமா இருந்தாலும் ultimately it has impacted survival rates for the better. So, we were talking so far about treatment of breast cancer. Can we prevent breast cancer?
$1 million. Yes. So, yes, certainly. And the like lifestyle da. Basically, and the lifestyle, it's not an overnight change. It's like we talk about a healthy pregnant mother is going to give birth to a healthy child.
Definitely.
And that healthy child is going to grow up a healthy adult. And then they're going to adopt also adopting a healthy lifestyle does not happen overnight. It's over a period. And updates, it's a cascading effect. Unfortunately, it starts off with PCOS and with infertility treatment, and then an unhealthy mother with assisted reproduction gives rise to an unhealthy progeny, and the lifestyle does not change, and it's like, it propagates, and it's just sitting ducks for all these problems.
Okay.
So it's so unfortunate that we are not connecting the dots.
Okay.
80% of my patients with breast cancer have diabetes.
Okay.
So and many of them are blood pressure patients, and many of them already have some arthritis type issues. So somewhere if you look at them, எல்லாருமே BMI அதிகமா இருக்கிறது one, overweight is or obesity is one issue. We all know obesity is a risk factor for breast cancer. நம்ம சொன்ன அந்த modifiable risk factors, the TOFI. So innocently எல்லாம் ஹெல்த்தி நினைச்சிட்டு இருப்பாங்க, விழுவிழுந்து ஒல்லியா ஓடியாடி எல்லாம் பண்ணான்னு. But you look at their visceral fat percentage, they'll have fat in the wrong place.
Yes. And
they will be diabetics, and they will be hypertensives. So somewhere the etiology is that one factor. For the elephant in the room is insulin resistance, visceral adiposity, inflammatory chemicals. So all this get activated, and it throws signals, and it throws all the cells
wrong signals. Yeah.
அதுல the insulin like growth factor pathway, mTOR pathway, இதெல்லாம் known to be associated with breast cancer.
Okay.
And so இதுக்கெல்லாம் fundamental root cause is metabolic health. And what does metabolic health mean? It's somewhere where, because of the way we lead our life, the layers of it will be food, the quality of food, quantity of food, seed oils, frequent eating. So நம்மலாம் படிச்ச காலத்துல, I don't know, I mean, you're a decade younger. When we went to school, காலையில தான் சாப்பிட்டுட்டு போவோம். It's not like,
you can't skip breakfast at all.
Generation came a little later. இந்த generationல காம்ப்ளான்லாம் கிடையாது. And then we went to school, had regular breakfast, and went to school, and we had our ஒரு டிஃபன் பாக்ஸ்ல ஒரு சாதம் இருக்கும், மேல ஒரு வெஜிடபிள் இருக்கும், and you cannot chuck there. You have to bring it back. அடி விடும். ஆமா. So சாப்பிட்டு வரணும். வந்தா evening they'll give you something. We all ate early, slept early.
Yeah.
We didn't have distractions with video games. We didn't have even... When I grew up, we didn't have TV also.
Okay.
And, so it was like that Olium up here in a veetla irukkom in a colony. And the Olium Chitraha were the only programs.
Yeah, that's it. I also remember quite well. Yes.
Agriculture related program, or
yeah,
there's nothing that we'll be interested in. On the half an hour பார்க்கறதுக்கு we'll have to be good for a whole week.
Yes.
So we slept well, we played,
physical
outdoor activities, we ate reasonably healthy food, unprocessed.
Life was simpler, I should say.
So
yes.
Like I said, food or quality, quantity, frequency of eating, and fiber, and quality processed oils, seed oils. They are very inflammatory.
Okay.
And rich in omega-6. It tilts the balance. So, there was a reason why they called it null ennai. No, it's null ennai. So, we gave up that, and we use heart healthiness, Anola, Savola, bran oil, canola. All these are actually the ones that cause heart problems, not heart health.
Protects your heart, yes.
It's not at all. Actually, one should ban them. The heavily processed industrialized oils.
Yes.
So that is a major culprit. Again, processed food, like, using maida, trans fats, all the wrong kind of fat, reusing oil, and deep frying things, they're all damaging. Occasionally you can have.
Yes, not every day.
Things frequent, it becomes unhealthy.
Ada, I saw somewhere, eat birthday cake. You eat cake every day, not only on your birthdays. There was in one place. So again, I thought, if you keep eating cake every day, you may have fewer birthdays. That's what I should say, Nanikra. That's what I thought.
When we all grew up, the sweets were a treat that you look forward to for a payday. Pay packet on he'll bring us some sweet on that day. Or it used to be a treat like Deepavali.
Birthdays, festivals.
I don't remember cake on those days.
Okay.
Macronet was only by one branch in that Mount Road. Lived in that area, I know. Deepavali sweets was made at home, and few people got together and made at home.
Yes.
Never bought these Deepavali sweets. So, இந்த மாதிரி தான் occasionally தான் பண்டிகை சுத்தி தான் sweets இருக்கும். Otherwise, sweets were not a regular part of it. Every day
is dessert. Eat dessert first. Life is too short. இந்த மாதிரிலாம் quotes தான் வந்து trending. What to do?
So, food like that, and then lack of physical activity, and we've all become couch potatoes.
Yes.
So that actually impacts on. See, everybody recognizes osteoporosis. Nobody recognizes sarcopenia. We start losing muscle from age 30 onwards, and unless we are proactively consuming healthy proteins and exercise, we lose muscle. When we lose muscle, we lose muscle is the biggest glycogen sink.
Yes.
And when you lose muscle, your insulin resistance
goes up,
and then cascading problems. So that exercise is very important factor. Stress, constantly fired with cortisol and adrenaline, and constantly, because your cortisol is high, your glucose is high. Your glucose is high, your insulin will be high, and then you develop insulin resistance. So stress is a major factor. Sleep. So people work to different shifts, and no social life, and don't sleep well. Again, your cortisol levels will be high, your insulin resistance happens. Because you are awake, you go on binge, and
it's all a vicious cycle. Yeah.
So, and then gut health. And people forget, gut health is related to food, it's also related to sleep, it's also related to
so many things. They run our whole life, the microbes which live inside. Yes.
It's like the second brain.
Yes.
It's like your second brain. And if you don't take care of it, like, from Parkinson's to Alzheimer's, to the extent, like now Alzheimer's is caused as type 3 diabetes.
Okay.
And it is completely preventable. And to an extent, early stages is completely reversible also. But unfortunately, we are shooting that, target, instead of hitting the
actual culprit.
So anyway, we got digressed. This is the prevention.
Okay.
And it starts right from pregnancy.
Okay.
Pregnant woman, if she decides to give rise to, I have to be healthy to bring about healthy children and a healthy progeny for the future for society. Again, it starts.
I can say that I'm really scared for the next generation, looking at the current scenario.
Where the parents are going to outlook the children.
Definitely, I think we will definitely get there. If not in this generation, in a generation or two, we are definitely heading there. And I talk a lot about the importance of losing weight and lifestyle. And as you said, it is the elephant in the room. And in Femiliarise, we actually had a acrylic elephant in the center, a huge acrylic elephant in the center of the room to highlight this, because that is what people do not want to see. They are ready to take medication, they are ready to take injections, whatever treatment, but they want fast results. It doesn't work like that. Health is not fast food at all, unfortunately.
Not understanding how all these things interplay and addressing one thing, and then do mistakes with other things. So dietitian போய் diet பண்ணி calorie counting பண்ணிட்டு,
yeah, that is not like very ஒரு இது மாதிரி போட்டு பார்க்குற மாதிரி.
Not all calories are equal.
Yes.
So you might actually calorie count and say ஒரு ice cream or 150 calories, and you have a healthy food with lot of sprouts, nuts in it, will also have 150 calories. You have cashew nuts, walnuts in it, and will also have 150. So is this 150 equal to this? No.
Yeah.
This 150 is far more superior because it has the fiber, it has all the micronutrients, it has all the polyphenols, it has everything that is good for
So
you.
nutrient dense, that's what we want rather than just calorie counting. So I think that's a very important message. So prevention of breast cancer and any cancer, many cancers, yeah, we can't say any cancer, starts with probably lifestyle modification, because that is what is in your control and is going to be good for your health and the health of the future generations, as you rightly pointed out.
Also, most importantly, prevention or secondary prevention. It is primary prevention, you don't get disease at all. Secondary prevention is where நமக்கு வந்தாச்சு இன்னொரு தடவை திருப்பி வரக்கூடாதுன்னா இவ்வளவு கஷ்டப்பட்டு கீமோதெரபி ரேடியோதெரபி சர்ஜரி மியூட்டிலேட்டிங் வாட் எவர் ஒரு ஹோல் இயர் கோஸ் ஆஃப் then திருப்பி வரக்கூடாதுன்னு somewhere you have to adopt all these things along the way. No, even now it's not too late to change. It will take a year or two to reverse everything, but it can still adopt all these things and then get life is more meaningful that way. You've undergone all this for what? To get it back again?
To get a healthy life again, live a healthy life. So இது வந்து நீங்க after post treatment follow up, that's what I wanted to ask. இப்போ ட்ரீட்மெண்ட் முடிச்சோம், நீங்க சொன்ன மாதிரி இந்த recurrence preventionக்கும் இது எல்லாமே ரொம்ப முக்கியம். And நீங்க வந்துட்டு do you guide the patients accordingly, ma'am?
We do some workshops, we do. Unfortunately, we're all so focused and
treating the disease.
Day is such that in a day you see 40-50 patients.
Yes.
And then you operate and your day is so full with already treating patients, and the rehabilitation and see in a clinic, how much can I spend with one newly diagnosed patient? I will probably give before or 10-15 minutes gyan, and most of it it'll all be absorbed. But na solradhoda nikkadu. Unfortunately, I'm the lone voice, you're the lone voice. But so many other people say, for example, I say don't drink fruit juice. So nature gave us fruit packed with fiber for a reason. Now you discard everything, deskin it, fiber, and then drink as juice. சாப்பிட்டா ஒரு ஃப்ரூட் சாப்பிடுவோம், சாப்பிட்டா 4 it's straight away giving you a fructose high. It's all going to go and sit and metabolize in the liver. அப்புறம் ஒரு வருஷம் கழிச்சு அல்ட்ராசவுண்ட் பண்ணா fatty liver grade 2 வரும். No, you're now again one more disease, non-alcoholic fatty liver disease, NAFLD. So you are opening a new Pandora's box altogether. And so it is somewhere in our mind we're all, see, fruits are good, they have a lot of nutrients, but fruits were meant to be seasonal. Fruits were meant to be the storage stuff for us. So but fruit, and you take with the fiber there's something called glycemic index and glycemic load. So the glycemic load will be lesser if you take it with fiber. Because and the fiber kammi pannidudhu. So but if you take it as fruit juice, straight high sugars as such. So இது நம்ம சொன்ன டாக்டருக்கு ஒண்ணுமே தெரியல. How can fruits are so
உடம்ப தேத்தணும், அதனால வந்துட்டு ஜூஸ் குடி.
Somewhere in our mind we've all got it all wrong with fruit juice. Now if I become the health minister, so first one of the rules that I put is never drinking any form of sugar.
Okay.
So you eat your sugar, don't, if at all you have to eat, don't drink your sugar. That includes
without knowing that you're drinking it.
That includes all the sugar in the tea, coffee also. So the sugar industry will be taking a big hit or will be taxed very heavily.
Okay.
The single most important factor, smoking ku kudutha athana investment. In fact, smoking, only a percentage of people smoke. Sugar, everybody is eating. So you, just like you put a warning signal for smoking, the danger symbol, you should put for sugar also. All your sugar packets, and no freebie distribution of sugar. Tax your sugar more than smoking.
So yeah, really good points. I think smoking and drinking are seen as addictions, but now everyone seems to have this addiction to eating, which is socially very acceptable and encouraged, unfortunately. So that is what is there in our culture, I would say. So I can see you're very passionate about that, and I saw on your website also that you have these follow-up meetings weekly or monthly and even yearly annual events for the patient, sort of all that is sort of important, because cancer is not only a physical treatment and diagnosis, it is a நம்ம குடும்பத்தையே புரட்டி போடுற ஒரு டிசீஸ். எமோஷ்னலாக, மென்டலாக, ஃபினான்ஷியலாக எவ்வளோ ஆஸ்பெக்ட்ஸில் they take a hit-ன்னு நினைக்கிறேன். ஸோ only concentrating on treatment, medication, injection, it's almost like infertility to a certain extent, I would say. Only concentrating on that and not looking at the other aspects is really not going to be it's not going to be a wholesome approach to the patient and solid நினைப்பேன்.
So unfortunately, the much focus that's put on treatment, they don't put on rehabilitation. I don't blame them, because it's a long treatment, 6 months to 1 year. And the treatment fitting on top. They want to see the face of doctors again. They don't want hospitals. Yeah. அப்புறம் கூட இருக்கவங்களும் ஃபேமிலியும் then be weary. எவ்வளோ நாள் ஒரு somebody who's active support பண்ணிட்டு the performance goes down from 100 to 40-50. அப்புறம் so much of other things, finance, the stress and so much of stress. அந்த அதில் வந்து அப்புறமா வந்து ரீஹாபுக்கு வா அப்படின்னா the financial bandwidth வேணும். So all our rehab programs are free. It's not charged. But வரத்துக்கு they have to take time. அப்பதான் வெளியில போய் சேர்ந்துருப்பாங்க, taking time off, கூட்டிட்டு வரத்துக்கு. So somewhere I think there's a mental block also.
They don't want to think about it.
Can't blame them. They are fed up of seeing. So that's why we don't get involved in the rehab programs. We've trained volunteers.
Okay.
So they do. So when peer-to-peer does, there's more acceptance.
Okay.
So that we handle it that way. But அப்போ வருந்தி phone numbers வச்சு கூப்பிடுவோம், வாங்கன்னு. அப்புறம் அன்னைக்கு என்னால முடியல, அடுத்த டைம் வரேன், அது மாதிரியும் இருக்கு. Sometimes these are
beyond our control. Each person, ultimately you can provide the resources, but help in varamode it should start from within. You have to decide what you're going to do. One important question for me is like, what do you see as the role of gynecologists in this fight against breast cancer? What do you think we should be doing?
So again, the same lifestyle instruction now at every visit, and because they are the first the point of contact. அப்புறம் clinical breast examination. And the right investigation at the right time. So mammogram diagnostic, உங்ககிட்ட வரதெல்லாம் diagnostic. Somebody has a complaint. Diagnostic has to be dealt with differently from screening. Diagnostics, the threshold to image should be low. And the imaging, it should be a reliable source of imaging. அதில் மிஸ் பண்ணக்கூடாது. அந்த இமேஜிங்கை வந்து கரெக்டாக ரீட் பண்ணி அப்ரோப்ரியேட் ரெஃபரல் அந்த சைக்கிளில் ஃபாலோ பண்ணால் தட் இஸ் மோர் தென் அட்.
ஓகே. ஸோ கரெக்டாக அவங்க வரவங்கள ஸ்க்ரீன் ஸ்க்ரீன் பண்ணுறது நார்மலி சம்டைம்ஸ் ஐ டூ தட் பிரெஸ்ட் செல்ஃப் எக்ஸாமினேஷன் ஈவன் இஃப் தே டோன்ட் ஹேவ் எனி கம்ப்ளைண்ட் வித் த பிரெஸ்ட், பிகாஸ் கைனகாலஜிஸ்ட்டை பார்க்க வரதே குழந்தை பிறந்ததுக்கப்புறம் எதுக்கடா வருவோம் அப்படிங்கிற மாதிரி இருக்கும். ஸோ டு யூஸ் தட் ஆப்பர்ச்சுனிட்டி ஐ ஜஸ்ட் யூஸ் த பேஷண்ட் ஆஸ் அ ஹோல் தான். ஸோ அகேன் அண்ட் ஸ்பெசிஃபிக் ப்ராப்ளம்ஸ் நீங்கள் சொல்லும் போது கரெக்டான டெஸ்ட் சொல்லி அதில் வந்து ஏதாவது இருந்தால் கண்டுபிடிச்சி அதுலேருந்து நம்ம எந்த ஸ்பெஷலிஸ்ட் கிட்ட ரெஃபர் பண்ண போகிறோன்னு அந்த கைடன்ஸ் கொடுத்தாலே இட் இஸ் மோர் தென் இனஃப் அப்படின்ட்டு. And last thing I wanted to talk about breast cancer பொறுத்த அளவுக்கு is breast cancer in pregnancy. A very, very rare thing, but such a difficult situation for the whole family. The mother as a new mother ஒரு ஆர்வத்தோட ப்ரெக்னெண்ட்டாக இருக்க போகிறவங்க ஒரு நிம்மதியே இல்லாமல் போயிடுது. And I recount this case for my mother's patient about a year ago, where she's only in her early 30s and she was diagnosed with a lump in the breast. I think வேற எங்கேயோ டெஸ்ட் எடுத்திருக்காங்க ஏர்லி ப்ரெக்னன்சிலேயே 7 வீக்ஸில். அப்போது எஃப்என்ஏசியான்னு தெரியல, இட் வாஸ் இன்டிட்டர்மினேட், ஒன்றும் இல்லைன்னு சொல்லிட்டு நீங்கள் சொன்ன மாதிரி விட்டாச்சு. தென் 5 monthஸில் வரும்போது ஷீ ஹேட் குவைட் அ லார்ஜ் லம்ப். Again underwent biopsy this time, turned out to be malignancy, and I think they referred her to you only. நீங்க ட்ரீட் பண்ணியிருக்கீங்க. So started with even chemotherapy when she was pregnant, because some drugs can be given in certain periods of pregnancy, and then after delivery, because மதரோட ஹெல்த்தும் பார்க்கணும், பேபியும் பார்க்கணும், சர்வைவல்ங்கிறதுனால 30 to 34 வீக்ஸில் C-sectionல டெலிவர் பண்ணிட்டு then she's undergone surgery, further chemotherapy, and doing well now. So is this a rare problem?
So this we call as pregnancy associated breast cancer. So breast cancer is occurring in a pregnant woman and breastfeeding woman. It is not, it is about like 5 to 6% again of all the breast cancers. young age-la varradhu. இப்போ mothers are getting older and older also. Yeah, the thing is, the challenge with PABC, pregnancy-associated breast cancer, is difficult to detect. Because the breasts are getting bigger, it's getting more firmer, and the எல்லாத்தையும் change எல்லாம் pregnancy associated change ன்னு dismiss பண்ணிடுவாங்க. And ultrasound imaging also is difficult. அந்த pregnancy timeல நம்ம mammogram பண்ண முடியாது. We can't expose to radiation. We do only ultrasound. Ultrasound பண்ணும்போது அந்த pregnancy lactation breast changes are a bit difficult to diagnose. And நிறைய lumps will get missed as fibroadenoma. அந்த ஏஜ்ல அதான் காமன். அப்புறம் ஒன்றும் இல்லை, some infection, inflammation, it will get passed. ஸோ அதுதான் சேலஞ்சு. ஸோ அதில் யூ ஷுட் எனி something unusual இதுன்னா it is always better to have a low threshold and freak. அதாவது இப்போ பார்க்குறோம், சரி இப்போ ஒன்றும் தெரியலன்னா ஓகே, மேபி சம்டைம்ஸ் a referral or another examination in a short period.
ஓகே, ஃபாலோ அப் பண்ணிக்கோங்கன்ட்டுன்னு.
So to have a low threshold to refer or re-examine is always better.
Okay.
The treatment wise, stage for stage is the same. The pregnancy makes it difficult for us to give chemotherapy, do radiotherapy or operate when, because you operate to anesthesia there, so when is it safe to give anesthesia, those kind of things apply.
Okay.
So if we find a PABC, pregnancy associated breast cancer, in the first trimester, we always ask for MTP and then proceed with treatment.
Okay.
The second semester, some chemotherapeutic agents can be given and then we push till the viability and then we operate. And then treat like everybody else.
Okay.
So another tough challenges இதுவும். So நிறைய time will be a precious pregnancy.
I know. And this was one such, because she had conceived after a long period of infertility, so they wanted to give it a good shot.
So the contrary, lot of pregnant people and the breast cancer patients treatmentலாம் முடிச்சு அப்புறம் then conceive, come and see us with the baby, that also happens.
Yes.
So the ER positive ones, we give tamoxifen for 5 years. After that, they take a tamoxifen holiday, and if they are able to conceive naturally, we ask them to go ahead. Triple negative, we don't put any restriction. So 1 to 2 to 3 years, after that you can conceive anytime. And the same with HER2 positive disease also. ER positive, we give them 5 years.
Yeah, I also seen, because treated for breast cancer, came back and delivered with me after a few years, Pathirken, as well as my very close friend. She had breast cancer which was treated and went on to have 2 more children after that as such. So at a very young age.
The fertility preservation is a big thing.
Yes.
People live longer with good quality of life, so they should also live normally. So young people, married couple arunda, we actually advise them to have இப்பெல்லாம் அந்த random start
protocols for IVF.
போய் நம்ம கீமோலாம் ஆரம்பிக்கிறதுக்கு முன்னாடி we ask them to actually have this, and then
so they do IVF, would take out their eggs, create embryos, freeze them.
மாதிரி சொல்றோம், but out of like அந்த ஏஜ் குரூப்ல வர்றது கொஞ்சம் incidence is less, but not many people take it up. But I've had a few one of my earliest patients 10 years ago, and she had this preserve. She went to Delhi, had it there because they're natives there, and then came back and finished treatment because both were ophthalmologists working somewhere here. Apparently, then they went back to have. She had a surrogate pregnancy though.
Okay,
but it's also possible that they have their own
child also, and
I think then like all these are possible now.
Yeah.
And unmarried is a bit of a challenge. And
yes. Freezing instead of embryo freezing, the oocyte freezing is also a good option, ma'am. Nowadays it has gotten much better with vitrification. You do have good survival rates even for oocytes, and as you said, unmarried na nam embryos question illa, so usually we opt for oocyte freezing. So fertility preservation is an option to consider, and they should definitely undergo counseling for it if it is a young breast cancer where they have not finished their family before exploring further options, because they are fixated on the cancer right at that stage, I think. Then
another thing we do is we give GNR channel along with so we suppress the ovary,
so again that protects the
thing. We use leuprate along with chemotherapy. We also use bisphosphonates, that also has some
protection.
No, mostly leuprate.
Okay, right. GnRH agonist for the
doing the entire chemotherapy, so it keeps that ovarian tissue suppressed and protected, and that is more acceptable to them
rather than IVF. Okay. So finally, any case you would want, இவ்வளோ years of experience, you've treated thousands and thousands of patients. Sometimes we have certain cases which really stay with us இல்லையா? அந்த மாதிரி ஏதாவது unusual-ஆ can you think of any instance?
Is almost one instance. Every patient becomes like that.
So then you can keep on telling stories. I'm sure. Yes. Okay.
Many. I mean, I think it's one organ, one external organ that is like a modified sweat gland type organ. So with so many, and then you basket into 4-5. Adilla, there is so much of spectrum, different age group, different challenges. And it's amazing how, and people often ask me, "Prasmatha pandre bore adikaliya?" It's not about, only you can empathize with what's happening.
Yeah.
Have a role in making their lives better. Abdina, whatever, continue to do whatever we are doing. Only thing, unfortunately, because of the challenges, see, we're also human. End of the day, we also, there's a lot of transference that happens.
Yes.
Sometimes, you go through your own challenges, and sometimes, we may not have been as informative to one or as nice to one, or so some of these challenges, sometimes I do feel, end of the day when I go to bed, sometimes this worries me, did I give my best to every patient? We're not able to give.
No, that we think like that itself is what sets us apart and makes us good doctors also at the end of the day. That's what, because we are so patient centric that we want to do our best, but we are also human at the end of the day, and we recognize that as a challenge which we personally face. That itself is something which not everyone thinks that way, I would say, ma'am. Let's go on to rapid fire as far as breast cancer goes, about certain common myths as well as common symptoms and doubts which the patient may have. Discharge from nipples always means cancer.
No.
Pain in the breast always means cancer.
No.
Any subtle sign which most people may not pay adequate heed to, so they underrate it as far as you're concerned, what would that be?
So people miss a lot of things.
Any subtle change which you say contour, symmetry, anything. Are breast cancer swellings usually visible on the skin?
Sometimes.
But advanced stages.
Yeah.
But early stage breast
Early
cancer
stage depends on the location. See, the breast volume is down here. Up here, it's generally the chest is flatter, particularly in older women. And even if it's a Nellica size tumor, it's going to be visible.
ஏன் நான் கேட்குறேன்னா, சம்டைம்ஸ் அந்த சூடு கட்டி தான் வந்திருக்கும் ஸ்கின் மேலே, அது கூட அவங்க பயந்துருவாங்க, அதுக்காக சொன்னேன். ஓகே. Breast cancer is always a disease of older age women. Younger people do not have to bother. Definitely, they have to be aware. Wire bras, do they cause breast cancer?
No.
Black bras?
No.
Wearing your bra at night? No. So all these are common myths. Bigger size breasts increase your risk of getting breast cancer?
It's not directly, but bigger size could also mean obesity, right?
Yeah.
So that way there is a risk.
Yeah, and suppose bigger, denser breasts, you may not be able to pick up things very easily. Antiperspirant deodorants, do they cause breast cancer?
I know, but parabens, they're known to actually cause damage. I mean, today's world soap, water bottle that we drink, the different
So all endocrine disruptors.
All your shampoos, on the vidathila, they may contain parabens. I tell people not to. So why do something artificial that irritates our body?
Using hair dye?
Hair dye, again, similar concept. Something, it may not have a direct causation. It's a small, these are all kuti
things which may
irritate.
Chemical straighteners, because there was an article which came about, especially in African American women, where they used chemical straighteners more often rather than people who didn't have that sort of hair texture.
In the hair is a kind of video, but hair on the scalp is going to get
and the fumes and the chemical exposure and the marine. Smoking, does it cause breast cancer?
The smoke has so many compounds that what these compounds do to each one of your cells when it's absorbed is something difficult to fathom.
And nowadays we see very many women smoking nowadays quite commonly.
But comparatively the awareness about smoking is, like you said, no smoking ko alcohol ko we have a label as it can be unhealthy, whereas sugar doesn't.
Yes.
But
And the rest is equal, yeah.
listen to it equals.
Second-hand smoke is also harmful.
100%.
Yes. Alcohol intake, does it increase the risk of breast cancer? Yes. Is there, I know all cancers are really, there is no best and worst. Is there a best type of breast cancer which would be more amenable to treatment?
Mucinous.
So
these are all good breast cancers.
And the worst type which we would not want?
Worst will be the aggressive, large, triple negative, node positive breast cancer.
Okay. Advanced stages. Can mammograms cause breast cancer to spread?
This is something has been debated a lot. There's no hard proof. The radiation levels are supposed to be safe and they're constantly working towards reducing it. And the screening interval, if you keep it reasonably lengthy, it is safe enough. That's what the literature says. But the thing is, my view is this. High risk, family history, genetic mutation, definitely do. Because we want pick it. The risk of it is much higher, pick it up early. And the no risk the focus should be more on healthy lifestyle and clinical breast examination. The mammogram should be like a secondary tool. So this may not weigh very well with everybody.
Yeah, that's your experience and your opinion.
General population advice பண்ணும்போது போய் mammogram பண்ணிக்கோங்கிறத விட go eat healthy, go exercise, go keep your weight in check, keep everything normal, sleep well, reduce stress is a better advice than say
only mammogram. Okay. Can a biopsy cause a cancer to spread?
No.
Risk of breast cancer with the use of contraceptive pills.
So the user, while using, the risk is slightly higher, definitely. For ovarian, it's protective. HRT is definitely more at risk of getting that. The use of more than HRT is like use of it after your natural normal menopause. Over 5 years, definitely there's a risk.
So in the older age group, and I think the risk of breast cancer with HRT was also in the slightly older age group in the WHI study.
I would say you should categorize HRT into two groups. One is HRT, one is HET, hormone extension therapy.
Okay.
So but now somebody goes and has a pan hysterectomy, oophorectomy at the age of 40.
Yeah.
Avangalukku HRT is important.
Yes.
And you're condemning her to a life, poor, miserable quality of life.
So it's only hormone therapy, not replacement.
The hormone therapy, potentially tentatively till 50 years you can give for a good quality of life.
Okay.
HRT in the conventional sense is somebody who's had a normal natural menopause at age 50 and they are having symptoms and they want to extend their hormonal milieu for another year. So, prescription renew, nobody doesn't
Comes back. Yeah.
After 7 years, 8 years, 10 years, will be on HRT. And we have evidence now to say HRT beyond 50, over 5 years, 7 years, and definitely there is a risk of breast cancer.
A little bit about behind the screen, because do we walk the talk as doctors? Do we follow the advice which we really give out to our patients? So we have this dream segment where I've just diet, rest, exercise, substance abuse, social connections of meaningfulness, as well as stress reduction. So just to know a little bit, why did you always want to be a doctor? Why did you choose medicine?
See, when we all grew up, there's only two categories of careers.
Medicine.
Doctor, engineer. Clever will become IAS or somebody like that, civil services. The moon option. So then I just kind of fell into medicine.
Medicine. And how did you choose surgery? Because surgery is still largely looked upon as a male-dominated field, and
I think it's also impressive by the surgeons that you see. I think I was influenced heavily by one doctor called Dr. Sridhar.
Okay.
And he was very good. First surgery that I saw him do, அப்படியே textbookல இருக்க மாதிரி ஒரு hernia repair he did. I was completely floored by it. அப்புறம் Dr. Rangabhashyam, Professor Rangabhashyam. I trained under him. Huge figures.
Yes.
And then somewhere I think I was also a little bloodthirsty.
Okay.
So it was naturally like I fell into it, and I was more comfortable in the surgical OT and with surgical patients.
Rather
right
than
my MBBS. Naturally we progressed in that.
And why did you decide to go into because surgeons, we do see lady surgeons quite commonly, but they operate a lot of across different parts. நீங்க breast மட்டும் choose பண்ணணும்ங்கிறதுக்கு
actually நிறைய surgeons even today இப்பதான் அந்த breastக்குன்னு ட்ரைனிங் ஒரு ஸ்பெசிபிக் இது இருக்கு. நாங்களா பண்ணும்போது because you're ladies, people gravitate to you. Then we call B&B surgeons, breast and bottom surgeons. Yeah. So I detested it. So I took up breast by chance. Actually, I wanted to be a pediatric surgeon. But I realized, no, my husband is a surgical gastroenterologist, and he is into like long hours and whatever. And both of us doing the same thing, because pediatrics is very, very intense.
Yes.
And the neonates la pandittu, you can't go home and sleep.
Yes.
So then I consciously. At that time, I was working with a breast surgeon in the UK. And in the UK, I would find, because I'm obviously male surgeon, and that unit, I was a registrar. Now, when we walk into the clinic, you will see the relief in that woman's face, that it's a woman. So, Western women where, there is not so much male women divide and discrimination. The gender discrimination is a little less there. Angaye, they feel more comfortable with the woman abdina. Then I thought, okay, maybe now place with this actually has to be something a big challenge. This is somewhere where I should focus.
Fill the gap
somewhere this was around 1994-95, and then but there was no route to train, and there's nothing like breast in appana UK la. And the decade and the breast units started forming, and people realized, there was one big paper published in BMJ where specialists treating breast cancer, the outcomes were better than generally everybody teaching. After slowly the concept of breast only, doing breast as a major part of your practice and doing other things for emergency work. NHS they gravitated like that. And by the time in the new millennium, breast unit and taniya vandirchu, then others should not operate on breast and vandirchu.
Okay.
It became medico-legally, a general surgeon treating without accreditation for breast, then you could be
penalized.
Only unless this is not available, then they cannot do. When a breast unit is available, they should refer to a breast unit. Other to put it into practice in our country, I came back in 2007, and the first place that I worked would not accept me as a breast surgeon.
Okay.
So general surgeon na potanga, and general surgeon, I don't do any general surgery. Anything other than breast. Why the hell today organ based practice is the in thing, and they advertise ella corporates breast clinic, specialized breast organ based practice, multi speciality, whatever. And I had so much resistance, so that is why I had to go and invest and do on my own.
Okay.
And so that's the story.
How Chennai Breast Center came about. So how many cases do you have any idea would you have operated on roughly?
Oh, I started off in 2007, it was 53 cases to start with in a year. Now I do close to 350. So, obviously it's a bigger team now. We all work together. And the setting up now, it's like a protocol-based treatment. Now, because we do that only one thing, lot of it is now protocol.
It'll fall into place, certain systems in place. And
so like that, so we also see a slight increase in incidence also, that is also explained.
And your experience
and then the bias, because now the ripple effect and the critical mass effect, you treat X number of patients in the same place, in the same city, and then everybody is going to hear your name spelled out
with relation to the place.
So adu oru influence.
How do you deal with the underlying stress and anxiety, which I'm sure is considerable even in oncology? So how do you de-stress?
There's a lot of questioning, and the nadula and the why, what, and so the
questioning,
dealing with that threat of death and death. It is a very, very difficult thing for the patients, and for us also. Like I said earlier, there's a lot of transference, and and there's always like, did I do my best? Could I have done better? Adella nariya varum. And I took to I was not a very ritualistic person. Then I took to understanding and we went a little spiritual. So I started with learning. I mean, they do a lot of spiritual shopping, like everybody else. And then finally, like I ended up with whatever I learn now. So we started off with a little bit of Bhagavad Gita, so understanding some little bit of Upanishads. Not that I know everything. So some introduction to it and some clarity on it. And then I picked up a little bit of Sanskrit also along the way. Somebody who, born in Tamil Nadu, we were all deprived of learning Hindi. So Devanagari script became a challenge. So we had to learn from ABCD. And so it was an eye-opener. And so amazing amount, wealth of information. And then you start becoming a little objective. And also, Vedanta and understanding the order of Ishvara and as is. So accept everything as is. Accommodate everything as is. And destiny, understanding what destiny means for each one of us. Other helps you deal with your own challenges in your profession. Somewhere along the way, we help somebody else to deal with their challenge also. Yes. So something, innocent or comment sollirpa. It will have a big impact, positive comment of course. It will have a big impact on their recovery, on their focus. So I think that maturity is over.
Definitely, and different people will go different paths as long as it gives us peace. And as you said, that positive vibe is transferred to the patients also. That's going to be mutually beneficial, I will say. Your greatest strength, what do you see it as?
And my dogs.
So your stress busters?
I'm a loner.
Okay.
I have a lot of friends, but I'm not a person who needs to connect with people all the time. So because I deal with people all the time, and like your staff and your patients, and so when the work is done, I just want to cut off the noise. I curl up with a book. Or these days, on these podcasts and videos that I select and watch. Yeah. And and then I always, of course, like I have a good routine of my early morning pujas. It gives me a lot of, I do a little bit of shloka chanting. We focus on, so it's meditative. And then I also am very keen on strength training, a bit of flexibility, a little bit of yoga, walking every day. Some days you can't. You have to accept that. Yeah. But most days. So all that. So after all this filling your day, you have
no time left as such. Yeah. So what is one thing which you would never do as a doctor who's been treating breast cancer for decades?
Personally. And so basically, I wouldn't, now that I know a lot of things that are detrimental to your health, I would now, hesitate to put anything sweet in my mouth. Okay. Occasionally sweet on ice cream is okay, but not on a regular basis. I would definitely I've never had the inkling for, when we grew up, alcohol was not mainstream. So I'm not used it at all to know what it is, and therefore I can stay away from it. And so stay with, definitely I can tell, it's definitely exercise, definitely eating healthy. Focus is sleep. Yeah. And we've all lost it for a very long period of our time. Yeah. So and then, like I said, somewhere I think we need to balance ourselves.
Yeah. For our own physical and emotional well-being.
Because if you don't walk the talk, if I'm going to be obese and if I'm going to be stressed and angry, how can you tell people not to do that?
Definitely. So I think that's where it's very important, as you said, even because otherwise as physicians, our disease rates are very, very high. We should not just give advice as lip service, but follow it ourselves as far as possible is very important. And finally, any next goals, ma'am?
I think, like I said earlier, I'm fed up of treating breast cancer. Now I want to prevent breast cancer. Yes. So lifestyle. I think people are hungry for knowledge. People don't know. You can't blame them for the lifestyle. They don't know. And so they think, there are innocent mothers who think Complan is great. I don't want to put any brand names to defame them, but health drinks is great and cereals is great. Cereal is up to po. I'd much rather send them without drinks than have them cereals. Sugar coated. Yeah. So these are all things that we have to go out.
We have to unlearn to relearn, I guess.
I think if the next 10 years, see, every decade of my practice now, I'm 57 now. So I think 60 plus.
I know. I think all of us have these sort of goals decade-wise. I know, because again, I got into a lot of lifestyle because I was frustrated seeing fertility. I think that is a very important component of women's health. And I keep telling my assistant doctors also, 50 and above, I think I'm going to cut back on obstetrics. I don't think, it's like getting too much for me. So I have been there, done that. I'm just going to concentrate on other things for now. So we'll see how it takes. So that's interesting to know that you're also going 60 plus, you're going to consider lifestyle as a major part, and as you said, breast cancer prevention, which is very, very important rather than only the treatment. So it was lovely having you with us, and we have spent a lot of time covering all things about the breast. I'm sure everyone should find it hugely helpful. So thank you very much for your time and patience, ma'am.
Thank you.
Thank you.
Lovely.